We will start our session. Welcome, dear colleagues. So today we will be discussing on clinical management of urothelial cancer and renal cell carcinoma. So first we will have some talk regarding urothelial cancer as well as renal cancer, and then we will discuss this in a panel discussion. So this activity is being sponsored by Merck and BMS. Thank you very much for this and giving us the opportunity to discuss this topic in detail. So without wasting much time, I would like to invite my first speaker, Dr. Amit Kumar. He is a senior consultant, medical oncology and hemato-oncology at Medanta Hospital, Patna. Welcome, Dr. Amit Kumar. He will be talking about neoadjuvant and adjuvant treatment in urothelial cancer, when and where. Over to you, Dr. Amit.
Yeah, thank you, Siddharth sir, for this opportunity. So without much delaying, so I will be just dealing about the bladder cancer, that is the urothelial cancer, the neoadjuvant and the adjuvant approaches, what are the indications, what are the trials, and how to select the patients in this group of. So as we know that for the urothelial carcinoma, so the stage 1, we are not, that's a very early, that is the domain of the urologist, we hardly interfere with that. But stage 2 and 3 cancers is the domain where we have to plan neoadjuvant or adjuvant therapy. Stage 4 is a different ballgame for which metastasis is only there. But for stage 2 and 3, which starts from what we say T2A to T4A, not 4B, mostly till T4A, along with N1 to N3 disease. So these are the areas where the involvement is up to going up to either to the adjacent organs or only up to the muscle invasive disease. Along with from N1 to N3, that is the nodes involvement below the para-aortic region. Any nodes which is involved, they can be taken for a definitive treatment and which requires a neoadjuvant or adjuvant approach in this group of patients. So the approach to the initial therapy, as we say, that for the stage 2 or 3 disease, we have to first look if the patient is a surgical candidate and is willing to accept the radical cystectomy or not. If it is he is willing to go for a radical cystectomy, then the next question is coming about his cisplatin eligibility, and that is to be taken care of whether about the performance status of the patient, like creatinine clearance, or the grade of the patient of the neuropathy. If it's less than 2, and then should be no significant hearing loss, means it should be less than 2 grade 2 hearing loss, and the heart failure, there should be no heart failure more than class 2 in this group of patients. In that case, we can surely go for a neoadjuvant intent therapy, which is a cisplatin based therapy. If it is not, in that case, the patient has to be taken upfront for a radical cystectomy or a bladder preserving trimodality. Trimodality meaning you have to go for a TURBT for this patient, followed by a concurrent CTRT in this group of patients. So this is the schema which has been mostly followed in the case of the neoadjuvant therapy. So during the time frame, so this urothelial carcinoma treatment is completely evolving. As we may see that the muscle invasive disease, the intent of treatment is also changing. For the non-muscle invasive, cure is the treatment goal, which are reducing the recurrence and dealing the progression. But for muscle invasive, along with cure, it's somehow we are now preventing radical cystectomy, also going for the triple modality therapy. But if the treatment, we say the surgery is the most important, cystectomy with full or partial cystectomy, along with the adjuvant or a neoadjuvant therapy, which is to be taken. Surely neoadjuvant holds an upper hand because the data are there supporting the neoadjuvant in this group of patients. So before treatment, we know a multidisciplinary approach should be always be a part of this urological malignancies. So which consists of not only about the patient, but their family, the urologist, the medical oncologist, pathologist, and other supportive care people has to be there. And there should be a good communication, that the patient has to be communicated what is he going to treat it, whether about the chemotherapy, about the role of the cystectomy, and how is that if the new bladder is being made, or if we are channelizing it the ureters, they have to be tell them, and we have to also take their decision what they want. So we have to take care about this. So, and why we are talking about neoadjuvant? Because the efficacy of radical cystectomy, if we say, though it is the curative modality, if the disease is earlier confined to stage 2, the still something around 35% of the patient will be going to die of the disease even after radical cystectomy. And if there is node positive, in that case, the 5-year disease-free survival comes down to only 30%. Means in those cases, 70% of the patient is going to die of the disease. So there we need a different treatment modality, addition modality to be needed in this group of patients. So what we see is that with organ confined disease, still there is a good outcome, but as we go for the extravesical extension or the lymph node positivity, the outcome of the patient with a radical cystectomy decreases. So any patient with T2 to T4A disease, as I already shown earlier, perioperative chemotherapy is indeed given to decrease the subclinical disease and improve the survival. Though the options for this muscle invasive disease are radical cystectomy or a neoadjuvant therapy followed by radical cystectomy, or if the patient is upfront going for a radical cystectomy, then you have to go with the adjuvant chemotherapy. And the fourth is the bladder sparing strategies, which most patients want. But still the outcomes are not so good as we compare with the radical cystectomy associated with neoadjuvant or adjuvant in this group of patients. So this is the algorithm which is now being changing throughout about the new ethnicity intent in this group of patients. We have to look if the performance status is good, the GFR is good, and standard chemotherapy. But if the GFR is decreasing and there's a PS is 2, in that case, radical cystectomy upfront without any neoadjuvant therapy. And but if the PS is poor, GFR is low, then no chemotherapy, no radical cystectomy, then you have to consider the trimodality. And in this group of patients. So why we are doing so? Because the outcome at 5 years after neoadjuvant chemotherapy or cystectomy in patient with muscle invasive is found to be improving. This 5-year OS is improved from to 50% from 45% if we take it as a whole in all the stages as a combined. But if we divide it by different subgroup of the staging, so with the stage 3, there is a more outcome benefit as compared to the stage 2 or earlier stage. And there's an absolute DFS benefit of something around 7%. So with this group of patients. So, and what treatment we have to choose? So the normal norm is to use a dose dense MVAC in young patient with good PS and no comorbidities because it shortens the time from diagnosis to surgery in this group of patients. But if the patient is older and you think that they are not going to tolerate a dose dense MVAC, then gemcitabine cisplatin is a reasonable alternative. And even in this group of patients, if the GFR is between 50 to 60, in that case, you can split the cisplatin dose in day 1 or day 8. Otherwise, what we are doing was approved is cisplatin 70 milligram per meter square on day 1 only. But if it is seen that the patient cannot tolerate, you have to split the cisplatin of 35 milligram per meter square on day 1 and day 8 to a maximum of 4 cycles, which we are giving in this group of patients. So the data regarding this neoadjuvant comes from both retrospective and prospective studies. And the earlier retrospective studies too shows that the patch CR rate is something around with GC is something 31%, with MVAC is around 29%. So overall is something 30% patch CR you are going to achieve with this neoadjuvant chemotherapy, which is found to be having a beneficial outcome in this group of patients. So, but still, even after this betterment, if you see in the real world scenario, apart from the scenario which you see the institutes like AMH, the urologists are not in favor of giving neoadjuvant chemotherapy. If the patient comes, they want to do either a radical cystectomy or they send for CTRT. The thing is that only something around 17% to 20% of the patients are of muscle invasive cancers are receiving neoadjuvant therapy because the urologists are concerned about who is going to benefit. They think that the cystectomy is delayed. If there's more than 3-month delay, then there's an adverse outcome in this group of patients, or about the toxicity of the chemotherapy, which may complicate their surgery. That is like renal impairment, wound healing, or the performance status of the patient may get worsened. So these are the concerns about the urologist, and so they may not send all the patients for neoadjuvant upfront. So, but still, what we see there is a shifting trend even in US. Now, what we are seeing that most of the patients are now coming for neoadjuvant somehow, especially the clinical T3, T4 disease patients. So they are now coming around 90% of these patients are coming, as compared to the T2 is still around 50% of the patients are coming for the neoadjuvant. And the most important concerns, as we say, is age and comorbidity, the delay in surgery, the marginal benefit, what they say is only a 5% benefit according to them. So why to give? And they are more want to give the adjuvant therapy as a better selection of the patient might be there. And further, they are afraid of the surgical complications. But still, what we see in recent trend, there is a trend for improvement in the neoadjuvant scenario with these muscle invasive tumors. So the first trial which came is as early in 2011 is also that the neoadjuvant MVAC studies in muscle invasive bladder cancer. So CMV is being used at that time, and it has clearly shows that the 10-year OS benefit is around 30% only radical cystectomy, otherwise in comparison to 36% in the patients who have undergone a neoadjuvant chemotherapy in this group of patients. So this MVAC is followed by, if we say the median OS difference, it is something around 46 months with cystectomy alone to 77 months with those who have undergone a median OS in this group of patients. So there is a definite benefit of around 20 months if the patient has receiving neoadjuvant therapy. So the meta-analysis, ABC meta-analysis also shows that if the patient receives a single agent platinum, the benefit is not so good. But if they are using a platinum-based combination, in this forest plot is clearly showing that neoadjuvant chemotherapy is better than any other modalities. So there is a phase 2 trial of accelerated, that is dose dense MVAC also as a neoadjuvant. So for the MVAC study, what we say that the dose dense are only phase 2 studies, but they are also showing a great benefit in this group of patients. We say that the down staging of the tumor is seen in 65% of the patient and up staging only in 18%. And if we see that the maximum thing is patient going up to the PT0, that the PACR is going up to the rate of 38% in the patient who is receiving dose dense MVAC as compared to in other groups. So this what we say, if the patient has achieved a PACR in these group of patients, the outcome is completely different from those patients who are not achieving PACR. So if we see the relapse-free survival is too high for the patients who are receiving PACR, and OS is simply a straight horizontal line. If so, after chemotherapy, if the patient develops a PACR, these patients are going to do very good even after 4 to 5 years of their survival in comparison to the patient who have not achieved a PACR. So this is not only that, because in this group of patients with the dose dense MVAC, something around 82% of the patients with N1 disease on imaging also achieve the N0 status. So no patients and further with N0 is found to be NPN positive. So what we see is that there is a good response to dose dense MVAC in all groups of patients, even in the node positive patients, they are showing a very great response. So this pathological downstaging is associated basically with a huge cure rate. So if we say the patient has cut down to after PT, that is post neoadjuvant therapy and surgery, if there is a disease is coming to the stage of T8, there the survival is very high as compared to the patient whose disease is still T3, T4 or lymph node positive. So always if the patient goes less than PT2, we say the cumulative survival is too high after chemotherapy, that is 5-year OS is something around 90%. As in comparison to the patient whose the disease is more than T2 status, even after neoadjuvant and chemotherapy surgery, so in that case, the 5-year OS going down to 40%. So the response to the chemotherapy is one of the huge marker how does the patient will behave during the course of their therapy. So this phase 3 trial, basically MVAC, what we say is the survival, if go with MVAC with cystectomy with PT0 is still not reached as compared to only cystectomy where the survival is only 11 months. So in this group of patients. And if there is a residual disease, even with MVAC, the survival comes down only to something around median survival is around 4 months. So achieving a PACR seems to be a very much important thing, and the outcome is completely different if the patient achieves the PACR as compared to the patient who has a residual disease post MVAC in this group of patients. So the 5-year survival is something of the order of 85 to 90% in this group of patients. So this is the study basically which has been recently published last year only, coming that the dose dense methotrexate has been compared with Gemcis in the patient as a perioperative therapy for the MIBC patients. That is the GETTER trial. So in this, the 4 cycle of Gemcis has been compared with the dose dense 6 cycles of MVAC, and what they have shown that the PACR rate in this group of patients with the gemcitabine GC is also 36% as compared to the dose dense MVAC rate is 42%. So, and this is the PACR rate, and even in the patient going to the down staging of the tumor further decreases by something around 70% in both group of patients. So in this. So what we see is that all patients, if we compare with the GEMSIS, those days MVAX has almost similar 3-year PFS and improved time to progression. And if we take as only the neoadjuvant setting in this group of patients, there is an improved 3-year PFS with GEMSIS, with basically dose dense MVAC as compared with GEMSIS, that is 66 versus 56%. So there's a 10% surely benefit, but there is no difference in the PAT-CR rate if GEMSIS is used as against dose dense. In this group of patients, it is 42% versus 36%. But however, we will say that dose dense MVAC increases local control more than GEMSIS, including the non-muscle invasive variant and organ confined disease. So in all the cases, if the patient is tolerable, it's always better to give a dose dense MVAC. If not, GEMSIS is a very good alternative to dose dense MVAC in this group of patients. And the toxicity, surely grade 3 toxicity is higher for the dose dense MVAC as compared with the GEMSIS, including GI toxicity and asthenia. And something only 60% of the patients has completed dose dense MVAC because of these toxicities. But we see that the overall survival is surely more or less much slightly better with dose dense MVAC as compared to GEMSIS, but still it is of the good time. Now coming to the timing, when do you want to start the therapy? So there is a single study which has shown that if you delay the neoadjuvant chemotherapy for more than 8 weeks after the diagnosis, in that case, there is a chance of upstaging of the disease. So you should basically start the treatment within at least 2 weeks. And the other thing is also said that radical cystectomy has to be performed within 7 months from the initial diagnosis. Otherwise, the outcomes of the patient becomes poor in this group of patients. So after this, how the other query is, since PAT-CR is an important thing, so how will you say that a patient is going to achieve a response or not? So what is beyond just giving chemotherapy? So something are the biomarkers which are now coming in recent time. That is, there are few mutations, that is ERCC2 mutations or the ATM FANG mutation or ERBB2 mutations. So these are the mutations which may show that there is an association with pathological response in this group of patients. If the patient has ATM, RB1 or FANG, the association with improved PT is more better in these group of patients. And the ERBB2 mutation causes association with a complete PAT-CR in this group of patients. So we can predict a response, that which patient is going to respond to neoadjuvant chemotherapy and which patient cannot is undergoing a response. So if a patient is having an ATM RB1 or FANG mutation, in these group of patients is going to have a very good response to the neoadjuvant chemotherapy as compared to the other patient who is having wild type of these mutations. So even this dose dense GEMSIS has been tried in the patients with deleterious DDR genomic alteration. So if the patient is having a DDR genomic mutation, these patients are having a very good relapse-free survival as compared to the patient who don't have this DDR wild type. So there is also now coming a risk-adapted approach in this group of patients, that if you do a TURBT, give them a chemotherapy followed by a repeat TURBT. And then depending on the TURBT result, if the patient is a PAT-CR, you can take for active surveillance. If the patient has a very good decrease in the disease coming down to CT1 or only T0 with mutation negative, in that case, you can give an intravesical therapy or can go for cystectomy. But a patient which in those who the disease is high, if it is more than T3, surely cystectomy, or if it is T2, then bladder sparing chemo, radiation, or cystectomy. So the metastasis-free survival depends on which therapy you are giving, and that's a non-inferiority design. The study has been planned. The final results is awaited. So there are other risk-adapted approaches also. So you can do the basically in the case with GEMSIS with nivolumab has been studied, and after that, after giving 4 cycles, depending upon the pre-staging workup and the TURBT result, the patient is being divided if presence of the residual or non-residual to nivolumab only or cystectomy in this group of patients. Similarly, you can also plan dose dense gemcitabine cisplatin, and after that you see the DDR deletion alteration. If there is an alteration, you can still spare the patient from radical cystectomy and can only continue observe the patient. Otherwise, if there is a DDR wild type, you can go for a radical cystectomy in those group of patients. So you have to now the further treatment is going to dependent on the molecular markers of the patients, and you can decide which patients are going to do better and which are not. So the future treatment paradigm for the muscle invasive is now coming based on the genomic landscape of this disease, whether it's a luminal or a bacillus common strain. In the luminal type, you will see that luminal papillary variant in which there is a FGFR3 mutation or amplification or a papillary histology. So these group of patients will say have a low risk to disease, but they are low likelihood that they are going to respond to the neoadjuvant chemotherapy. In comparison to the luminal infiltrated, in there is also what we say that there is a low response if there is EMP markers are present to chemotherapy as compared to the luminal where they are giving targeted therapies. Where the basal squamous cell is this group of patient is more likely to respond to cisplatin based therapy in this group of patients. So there are many clinical trials with now a neoadjuvant therapy which is being taking the IO in combination, and we see the PASCR rate is coming to the like pembrolizumab is something between 30 to 40%. Whereas with Atezo, also there is a Abacus study which is showing the trial of 30 to 40% of PASCR. Whereas nivolumab, the blast trial with gemcitabine Nivo is PASCR is the highest. What we say is going up to 50% in this group of patients. So this is a Pembro study which is showing based on the tumor mutation burden and the response with high tumor mutation burden or the high CPS score showing a greater response. Whereas the Abacus trial design is still giving week 0 and week 3 of Atezo, and if there is a response, so this patient is also having a PASCR. This is ongoing and showing a good PASCR. If the PDL1 positive is something around 40%. If PDL1 negative, the PASCR rate is 16% in this group of patients. Further, we say which patient is going to respond. It depends on the inflammatory markers of the tumor. So if there is an inflamed, there is an increased response. Otherwise, if it's immune desert or immune suppressed, they are found to be less response. So if we see that if there is an FGFR3 mutation, these patients are the non-T cell inflamed tumor, and they are not going to respond to immunotherapy. So FGFR3 mutation is somehow a marker that the patient is not going to respond to immunotherapy. So if the patient is having this luminal infiltrated one, and we may say that FGFR3 expression is associated with poor response. So we have to look whether it's a luminal papillary. You don't have to give immunotherapy in this group of patients. The latest drug which is coming in the neoadjuvant area is the enfortumab vedotin, which we know that FGFR3 inhibitors and 3 cycles of which we are given before the treatment. And it shows a PASCR rate is also of the order of something around 36% with this also. With the down staging is 50%. So we are seeing an anti-tumor activity with this enfortumab vedotin also in this group of patient. Now quickly going to the adjuvant. So regarding adjuvant, the only thing is that you have to go with a neoadjuvant. The data is good with that. But if the patient is a high risk disease, so high risk are those patients who are T3 or T4A or node positive, and they have not received the prior neoadjuvant therapy. So these group of patients, if cisplatin eligible, go for the adjuvant therapy with MBAC or Gemcis. If not, then you have to go with an adjuvant nivolumab in this group of patients. Otherwise, if the patient you have given a neoadjuvant chemotherapy upfront, and if there is still a residual disease present post surgery, it's a adjuvant nivolumab can be given in this group of patients. So adjuvant chemotherapy rationale is basically if we are widely used outside of the clinical trial because if the urologist feel they want to go for the surgery upfront, and if there's a high risk disease T3, T4 or node positive to improve the OS, they give the adjuvant. There are multiple trials which are showing that the adjuvant may have some survival benefit, but all these trials are closed early due to poor accrual. So the data are very much dicey in this, but in the real world data, there are few data which shows adjuvant chemotherapy may have some role in the case if they are a high risk. So to conclude with the adjuvant, we may say that a combination therapy improves OS. Benefit is larger with those with a node positive disease. So the timing of administration of adjuvant as soon as the surgical recovery permits, that it should be between 6 to 8 weeks post-operatively and no later than 3 months of radical. So this is the time you have to give this. And there are some immunotherapy also. I am bigger study the Atezo, which has shown no benefit. Nivo has clearly shown a DFS benefit, and so it has been approved as adjuvant. Where is the role of the ambassador? The trial report is awaited in this group of patients. So this is the adjuvant nivolumab for high risk MIBC, which is clearly showing a disease-free survival of at 12 months of around 63% as compared to 46% in the placebo group. And this is being seen in almost all the subgroup with PDL1 expression of 1% or more, or even with the less. So if there is expression 1% or more, this benefit is slightly higher, but it is present in both the group. So the neoadjuvant approach depends on you have to take care of the presence general condition, any hydronephrosis, lymphovascular invasion, locally advanced tumor, if there is any lymph nodes, the renal function has to be taken, and the clinical delay in presentation and the performance status of these. So there are surely a benefits of both the neoadjuvant or adjuvant, as we have already studied. But which regimen? So what we'll say, the dose dense MVAC has to be preferred over standard MVAC. Perioperative Gemcitabine is a good alternative to dose dense MVAC, and we have to give it for 4 cycles. And carboplatin should never be substituted in this group of patients because there is no data that is going to improve in neoadjuvant or adjuvant setting. With this, I would like to end my talk. We'll take a question, I think, in the next session.
Thank you, Amit, for this elaborated talk. And if there is any question, we can discuss because we have some time with us.
Sure.
I think no one has question. So as you have summarized that for all patients who are young and fit enough should receive a dose dense MVAC, and for all other patients they are eligible for NSFT, they should do gemcitabine cisplatin. We generally go ahead with 4 cycles, and there is no role of carboplatin in neoadjuvant setting. There is no adequate data for that. So I would like to invite my next speaker, Dr. Amit Agrawal. He is Assistant Professor, Department of Medical Oncology, AIIMS Raipur. He will be talking on improving survival and quality of life in frontline advanced RCC with CTLA-4 and PD-1 inhibition. This session is sponsored by Bristol Myers Squibb. So over to you, Dr. Amit Agrawal.
Sir, actually, I'm on my way. It will take me around 10 minutes. I was thinking about 6:40. So.
Okay.
I just informed Ms. Gitika.
Okay, no issues. So actually, one of our talk has been cancelled. So that's why there was some time glitch. So Dr. Ravi Jaiswal, are you there?
Yes, sir.
Dr. Ravi, if possible, can you start with your presentation?
Yes, I am okay.
Okay.
Just give me a minute. Yes.
So Dr. Ravi is a Senior Consultant Medical Oncology at Ramakrishna Care Hospital, Raipur, and he will be presenting on current updates and future perspective on management of renal cell carcinoma. Over to you, Dr. Ravi.
Is my screen visible?
Yes, sir, it's visible.
It is visible.
So very good evening to all of us, Dr. Siddharth sir and the new Radiant team, as well as our guests who are joining us outside Raipur. So we just had a wonderful talk by Dr. Amit and we have a lot to follow. So what I am going to discuss today is about renal cell carcinoma, and I'm going to talk about what are the current updates and what are the future perspectives. Let me just fix it. All right. So I hope I'm clearly audible and my slides are visible. So what we are going to discuss in next 15 or 20 minutes is this: an overview. We will have a look at what this renal cell cancer is all about, how is the disease biology, how the treatment has evolved from cytokines to TKIs to cytoreductive nephrectomy to immune checkpoint inhibitors. Then we are going to talk about advanced renal cell cancer, what new is happening and what is the first line and subsequent strategy. And in the end, we are going to talk about adjuvant therapy for RCC and what new is coming up in that scenario. So when we talk about renal cell cancer, we always knew that this is a chemo-resistant tumor. And that is the only reason why there had been no chemotherapy ever for this cancer. A lot had been tried prior to 1980s, but nothing worked for this cancer. We also know that this cancer is known to have spontaneous remissions. And this was in fact one of the first cancers where spontaneous remissions were documented. And a lot of theories were said about that, right? Like the Ascobal effect, the immune response. Then was an era of cytoreductive nephrectomy for metastatic disease. And it was also attributed to the immunological phenomena of this cancer. Historically, cytokines had a role. We had interferon alpha, high dose IL-2. But the high dose interleukin 2 led to approximately 7% durable clinical response. And in fact, 7% was the complete remission. And this was very, very fascinating as to why this IL-2 led to 7% of durable complete remissions. And this was way back in 1988. But subsequently, it was found that there was no major benefit because a lot of patients had a treatment-related mortality to the tune of 7%. Majority of patients who have renal cell cancer, they have a localized disease, and these patients undergo a nephrectomy. 1/3 of the patients out of them progress and they would need a systemic therapy. And 30% of patients de novo present with a metastatic renal cell cancer. We are aware of the risk stratification, the MSKCC and IMDC, and very soon we are going to have the genomic models like we have for other cancers to risk stratify these patients better. Because the better the risk stratification, the better you decide on the treatment. About cytoreductive nephrectomy, patient selection is very, very vital. Earlier, it was a go-to option, but now this surgery is reserved in upfront setting for patients who have more favorable features, like patients who have very few or minimal extrarenal disease and very few IMDC risk factors. Only this is the situation where there's actually some benefit with this surgery. A word about active surveillance. So active surveillance in metastatic disease, this idea was originally given by Dr. Brian Renal. And before initiation of systemic treatment, patients should be considered for active surveillance. This was published as a phase 2 trial of 60 patients. The logic behind this was that there's a cohort of patients in metastatic RCC who have a very indolent disease, and we can delay treatment, initiation of treatment for this patient by a couple of years or so. Are my slides moving around? My slides are moving?
Yes. Clearly visible.
Yes. So renal cell cancer is a highly immunogenic tumor, and it frequently expresses PD-L1. And that was the rationale why PD-L1 targeted therapeutic approaches became successful for this treatment. So if you see the disease biology, 24% of clear cell RCC express PD-L1. And when you talk about the tumor microenvironment, more than 50% of renal cell carcinoma tumor infiltrating lymphocytes, they express PD-L1. But remember, expression of PD-L1 is considered to be a poor prognostic factor. Though they respond to immunotherapy, but it is considered to be a poor prognostic factor. When we talk about what are the approved treatments for advanced RCC, when we had a pre-TKI era, so that was prior to 1990s, the median overall survival of patients with metastatic RCC was 12 to 15 months. With the introduction of TKI, so there was sunitinib, sorafenib, pazopanib, axitinib. So post TKI, the survival just doubled to 24 to 36 months. And with the introduction of immune checkpoint inhibitors, the survival is getting longer. Let me tell you, the median overall survival has not yet been reached for a lot of these immunotherapy trials. The longest data we have is for the EP-Nivo combination. We have now 4-year follow-up for this study. The median overall survival is yet to be reached. So just let's understand the evolution of treatment for renal cell cancer. So 1980s that we've discussed was the interferon era. 2000 was the era where your sunitinib, sorafenib came into the picture. Then we had the mTOR inhibitors, everolimus. We have pazopanib. We had a specific VEGF blocker like axitinib. But it was only after 2015-16 where the immunotherapy agents came into the picture. The first was nivolumab, which was tried in the second line. And subsequently, we had a combination of nivo with EP. And then we have immunotherapy combinations with the TKI, like the pembro-axi, the avelumab-axi. And then recently, we have two more important trials, which is the lenvatinib pembro and cabozantinib nivolumab. So now let us quickly see what has happened. So this is the first study which showed the benefit of immune checkpoint inhibitors in renal cell cancer. This was in second line where they had compared everolimus versus nivolumab, and it was found that your overall survival increases by 6 months. So 6 months overall survival benefit in the second line setting prompted the use of these drugs in the first line setting. And when we talk about the first line setting for metastatic renal cell cancer, this figure shows you 6 trials, which are phase 3 randomized RCT. The first on your extreme left is Checkmate 214. That is your EP-Nivo study. The primary endpoint was PFS and overall survival. The second study was the Javelin study. So it is your avelumab plus axitinib. And along with the same time came the Brian Rini study, which was the Keynote 426. Here he used pembrolizumab with axitinib. So axitinib is common here, but the IO immunotherapy drug is different. It is pembrolizumab versus avelumab. The endpoint of Javelin was PFS, whereas for the Keynote 426, it was PFS plus OS. Then we had another study, which is the CLEAR study. So CLEAR study uses lenvatinib with pembrolizumab. And the other study, which is a recent study, is the Checkmate 9ER. So Checkmate 9ER uses nivolumab with cabozantinib versus sunitinib. The other arm had EP-Nivo versus cabozantinib. Sort of all these 6 studies that have displayed on the screen, the Javelin Renal 101 we won't be discussing further because it was a negative study. The study did not meet the endpoint of overall survival benefit. So we won't be, and hence avelumab is not an attractive option anymore for treating this patient. We would be speaking about nivo-EP, pembro-axi, len-pembro, cabo-nivo, these studies in subsequent slides. So this was about first line. So first line, like we have these 5 studies that had just displayed you, clear survival benefit in 5 studies out of 6. Immunotherapy, we all know, is go-to drug for these cancers. First line treatment is very, very, very important for renal cell cancer because we know in second line and beyond, though we have options, these patients don't really do well. We have axitinib, we have tivozanib, cabozantinib, everolimus, len with evero, but the side effect profile of this drug, the rashes, the hypertension, and the quality of life, it is my experience has not been very great in treating these patients on second line. Another important thing is we always talk about the sarcomatoid histology. So this majority of RCCs and that we have been discussing is all about the clear cell histology. But something like a sarcomatoid is a very, very bad histology where your TKI don't do much. And it has been shown that if they have to have some benefit, it is with immune checkpoint inhibitors. So we won't be discussing much about the second line and beyond in metastatic RCC. We would go back to our focus on how first line is most important. And I will tell you why one of the 5 options is my favorite. So again, let's go back to our first line treatment options. So the first is your EP-NIVO study. So if you look at the EP-NIVO study, we have maximum follow-up for this study. So we have more than 4 years of follow-up now, 4 years of data. And the study said that in the intermediate and the poor risk group, there was survival benefit using this combination versus sunitinib. But in the favorable, you as well as you use sunitinib. EP-NIVO did not add benefit in terms of survival for the favorable risk category. Coming to the keynote 4 to 6, that is Pembro-Axi. Again, it had patients with favorable, intermediate, and poor risk. Overall, it was found that irrespective of your risk stratification, this treatment arm, that is Pembro-Axi, benefits everyone. Similar was the scene with Cabo-Nivo and Len-Pembro study. The most important point here to note is that the amount of patients that fall into favorable and intermediate risk category. So the Pembro-Axi study had relatively more patients in the poor prognostic group compared to your Len-Pembro study. So that is one thing that I want you all to remember from here. But the overall survival and the progression-free survival across all these studies is almost the same. So these are cross-trial comparisons, and 1 to 2% here and there should not make us think that Len-Pembro is a better drug. So if you see these landmark overall survival at 12 and 24 months, so it is almost 83, 90, 86, 90, again 71, 74, 72, 79. So it is not very, very different. And all these drugs, in my opinion, in the category of the patients that underwent in this study should be considered the same. Though the Len-Pembro study showed that it is slightly beneficial, but it is a cross-trial comparison which should not be considered. About overall survival, an important point that I want to share with all of you is that look at this. Everybody here gets a overall survival 0.7, 0.7, 0.7, 0.7. So hazard ratio is almost same. That is 30% risk reduction. But when you come to the early onset of benefit, you see the clear, I have marked it here. So the checkmate 214, if you see in the first 6 to 7 months, the curves, they overlap. That means the actual benefit is seen after 6 to 8 months. So if you have a patient who you feel requires an early onset of response, then maybe the other combination, that is the TKI IO combination, like the keynote 4 to 6 or your clear Len-Pembro study or your Cabo-Nivo study, gives you early separation of the graph. So that should be considered. Again, with this is again to show the similar phenomenon that why early onset of action with this study may be beneficial for a certain class of patient. But yes, it doesn't matter for a lot of the group of patients, because your ultimate endpoint is overall survival, and which in my opinion is same across all the group. When we talk about response rates, complete response rates, and primary progression rate, this graph is very important, because you see the checkmate 214, CR rate 12%, response rate 39%. But when we talk about the pembro-len study, look at the response rate, 71%, and look at the CR rate, complete response, 16%. So this, in my opinion, is significant. So getting 16% CR rate, because that is what you want from your immunotherapy drug to do, that the tail has to be long. A lot of patients should have a sustained complete remission. So highest you get among the group is for pembro-len study. Also, the rate of primary progression is slightly higher for nivo-EP compared to other studies. When we talk about toxicities, yes, there are toxicities. There would be rash, there would be scrotal rash, there would be rash everywhere, there would be hand-foot syndrome, mucositis, hypertension, but it is manageable. It is not that it cannot be managed. I still remember one patient I had on Pembro-Axi, and after 6 months, he had very bad rash. It took 1 month to subside. We even had to put him on oral steroids. But yes, after 12 months, he is in almost complete remission. So if you manage the side effects well, I think it should not be a major problem using this drug, because 30% patients have treatment discontinuation rates across all these studies. That is 1 in 3 patient has a treatment discontinuation rate. So managing toxicity is also very, very important. So my take home message number 1 from this first discussion is almost everybody who could afford should get an immunotherapy drug for renal cell cancer. The most important question that comes to my mind is who does not get immune checkpoint drug, or who gets TKI alone. So I was thinking this yesterday night, and I could figure out that maybe someone who's got a very poor performance status, maybe who could not afford, and in whom immune checkpoint drug is absolutely contraindicated. But apart from that, almost everybody gets an immune checkpoint inhibitor. The third and most important is the nivo-EP combination is not for favorable risk, whereas the IO-TKI combination can be used even for favorable risk. Now I'm shifting my attention from metastatic renal cell cancer to localized renal cell cancer. So what about localized renal cell cancer? If we look at the Leibovitz scoring system, so Leibovitz scoring system included your T stage, nodal stage, Fuhrman's grading, and all that stuff. And it had given 1 point to each of the score. And it was found that the more Leibovitz score you had, the more chance of metastasis and the more chance of progression after your surgery. So that indirectly tells you about the poor prognostic risk factors. So look at this. So somebody who's got 0 or 1 score, his metastasis-free survival is almost 90 to 100%. That means very few the disease would come back. But if you have more such risk factors, like your T stage is higher, your nodal status is higher, your Fuhrman's grading is higher, and if you get to a score of more than 8, the chance of these guys to get their disease back is almost 80%. So only 20% could be treatment free for their localized RCC. And that tells us that there is a lot of scope for improvement in survival for this patient if a good adjuvant drug is available. A lot of these years, we had a lot of negative opinion about adjuvant RCC because of all these trials that have been displayed here. We had Assure, Atlas, SOURCE, Protect, Everest, everyone negative apart from the Abstract trial, which used sunitinib and which had its own problems. So sunitinib was, though licensed by FDA and not by EMEA, it was never widely approved across clinicians, and adjuvant treatment was never a standard of care for this patient until this landmark study, which is Keynote 564. So what is Keynote 564? Keynote 564 is a randomized, double-blind, phase 3 study of patients who have a clear cell RCC, who belong to either intermediate or high risk category, who did not receive previous systemic therapy, and they were randomized either to get a pembrolizumab versus a placebo. Remember, they don't have patients with your favorable risk. We are talking only about intermediate and high risk, and we are giving them either pembro or nothing. And
Dr. Ravi, sorry to interrupt. Please try to conclude in 2 minutes.
Okay, I'll be done in 2 minutes. So what did this study tell us? So this study said us that your disease-free survival, the hazard ratio for disease-free survival is 40% better. So this study actually met its primary endpoint, which was disease-free survival. The overall survival data of this study is yet to be matured, and hence currently it cannot be considered a standard of care, but yes, it is a potential new standard of care. So yes, there is light at the end of the tunnel, even for adjuvant therapy. We just need to wait for the overall survival data. So to quickly summarize in 1 minute as to what I've spoken, we've discussed about the biology of renal cell cancer. We've talked about how the evolution of treatment has happened from your interferons to interleukins to TKIs to immune checkpoint inhibitors. We've spoken about the multiple 6 first-line trials and why Len-Pembro is slightly better than others, why we should not be using Nivo-EP in the standard group. We've spoken about the adjuvant space. We've talked about pembrolizumab as a potential adjuvant option. So a lot of positivity coming from renal cell cancer. That's all I have. Thank you so much. Thank you for your attention.
Thank you, Dr. Ravi, for your wonderful presentation. It was very detailed and it has almost covered every aspect. And it has bring to a very important point that active surveillance is in fact a strategy in metastatic renal cell cancer. There is some upcoming trials and there can be a potential new standard of care in adjuvant setting as well. And we should all try to see the risk stratification and try to incorporate newer treatment in our management. So now I would like to ask Dr. Amit Kumar Agrawal. He is Assistant Professor AIMS for his talk on improving survival and quality of life in frontline advanced RCC with CTLA-4 and PD-1 inhibition. Over to you, Dr. Amit.
Thank you, sir. I'm sharing my slides. Is my slides visible, sir?
Not yet.
Still not visible now.
Can I open from my side?
Yes.
Is
yes,
there any
you please
internet issue?
Yes, please open from your side. Yes. Good evening, everyone. Sorry for the delay. So I will be discussing about the combination of Nivo-EP in RCC. It is how it improves survival and quality of life with this use of this combination in frontline advanced RCC. Next slide, please. So we know that in renal cancers, the RCC is the predominant histology. 90% of the cancers are actually RCC, and amongst RCC, for the management purpose and for the staging purpose, for the management as well as the prognostication purpose, we chiefly divide into clear cell as well as clear cell and non-clear cell RCC. And non-clear cell can be anything papillary, chromophobe, collecting duct, and so on. Next slide, please. We know that what is the disease burden of metastatic RCC. Many of the patients actually present with metastatic disease upfront, around 30%, and 1 year survival for these patients is around 36%. And this was chiefly before the era of TKI, and now upcoming the role of immune checkpoint inhibitors. And you can see here the 5 year survival in the tune of 12% without these use of these novel agents. Approximately 40% of RCC patients die of metastasis. Next slide, please. So how the role of immunotherapy came into the RCC arena? This was the first phase 3 trial where nivolumab was used in the second line and beyond, and it was compared against then standard of care in second line, that was everolimus. It was a phase 3 randomized trial where nivolumab 3 milligram per kg 2-weekly dose was compared against everolimus 10 mg OD, and it was given until the progression. The primary endpoint was overall survival. Next slide, please. And we can see here the hazard ratio 0.73. It means there was 27% reduction in the risk of death with nivolumab compared to everolimus. So definitely, after the use of one or more lines of TKI, which was predominantly sunitinib at that point of time, still with the use of nivolumab, there was significant improvement in the overall survival. If we compare against the then second line, which was standard of care, was everolimus. And we can see here at the 5 year, the survival rate was around 26% as compared to 18% in everolimus arm. So there was definitely good benefit with use of immunotherapy that was proven with this trial, and the median overall survival in this trial was around 26 months. That is also a good survival. Next slide, please. So definitely there is unmet need in the area of renal cell cancer, and it was actually before the newer combinations like immunotherapy plus immunotherapy or immunotherapy plus TKI came. The picture was totally different. It, as Ravi Jaiswal sir already told, it started from interferon, interleukin, and then the era of TKI followed by immunotherapy started. Now we are seeing too much of survival benefit with the use of combination of IO plus TKI or IO plus IO. Next slide, please. So we can see here before actually the era of TKI or immunotherapy, the survival rates and the progression-free survival, objective response rate were very minimal. But now the scene has drastically changed. So what we want with any agent in cancer trials or cancer patient, we want them to survive for a longer time with good quality of life. And if possible, if we can achieve complete response, that will be icing on the cake. And we want durability of response. We just do not want the response. It should be durable. And that is most important. And that is what we are seeing with the use of immunotherapy. Next slide, please. So what is the rationale for immunotherapy? Next slide. In renal cell carcinoma, we know that RCC is not a cancer which is very much chemosensitive. So that's what the tumor microenvironment is totally different. There are immune cell infiltrates, and historically we know that there was an era where interleukin, interferon have been used. So definitely it also suggests that there is always immunotherapy was always there in the management of RCC. These studies have shown that there is increased level of regulatory T cell, memory T cell, and CD4 and CD8 T cells. So that suggests there is immune mechanism, immune escape mechanism is involved in the proliferation of cancer cells in RCC. That's why immunotherapy might be very much active, and we are seeing that in the studies as well. Next slide, please. Next slide. So we are talking about combination of anti-PD-1 and anti-CTLA-4, that is combination of nivolumab and ipilimumab. So how the combination works better as compared to if we use nivolumab alone, that we will see how what is the mechanism of action. Next slide, please. So we know that nivolumab anti-PD-1, it restores the anti-tumor T cell function. It enhances the pre-existing T cell response. It increases the cytokine production. Basically, the immune escape which has happened, which is now inhibited. So there is increased immunity in the tumor microenvironment. It leads to more presentation of foreign antigen, that is cancer cells or cancer antigens here, which are presented to the macrophages, and ultimately we see in the form of tumor cell lysis or cancer cell lysis. Similarly, the anti-CTLA-4, that is ipilimumab, it induces de novo anti-tumor T cell responses. The dendritic cell T cell interaction in lymph node is increased, and we know that CTLA-4 is expressed on T cell and it inhibits T cell activation. So when we give anti-CTLA-4, the T cell activation is increased, and the combination of both these agents actually leads to uh, change in the tumor microenvironment, as well as activation of T cell in the periphery, which ultimately leads to destruction of cancer cells or foreign antigens. Next slide, please. So I've already told through the inhibition of CTLA-4 pathway that acts mainly in periphery, there is distribution of activated T cells, which ultimately comes to tumor sites, and it results in activation of the immunity or immune cells in the tumor microenvironment, ultimately leading to tumor cell lysis. Next slide, please. So this is the IMDC risk scoring criteria, or we also call it as a Hank criteria. Based on these factors, we divide into favorable, intermediate, and poor risk. Next slide, please. And there is a clear-cut demarcation in the median overall survival. The favorable risk, the median overall survival was 43 months, and intermediate, it was around 22 months. In poor risk, it was 7.8 months, but it was at that time of that trial. But now we will see the things will be changing drastically with the use of combination of Nivo plus EP. Next slide, please. So we are coming to the main point of discussion, the CheckMate 214 trial, the combination of nivolumab plus ipilimumab. Next slide, please. So almost 1,000 patients, the upfront advanced RCC with good performance status. It was Karnofsky performance status, but if we talk about ECOG, it would be around 0 to 1. So they were randomized into 1:1 fashion into two parts. The one arm was giving combination of Nivo plus EP for 4 cycles, followed by Nivo maintenance. And the other arm was giving standard of care sunitinib. That was 50 mg OD at 4 weeks on, 2 weeks off schedule. The median follow-up in this trial was around 55 months, and the minimum follow-up was around 4 years. And the treatment was given until the unacceptable toxicity or disease progression. The primary endpoints were overall survival, objective response rate, and progression-free survival, while secondary endpoints were the same criteria in the intention to treat population, and also the adverse events. The nearly 80% of the patient in CheckMate 214 were either intermediate or poor risk as per the IMDC criteria. Next slide, please. So here the dosing schedule, we know the Opdita is given 3 mg per kg, and the Yervoy, that is ipilimumab, is given 1 mg per kg. This is given for 4 cycle every 3 weekly, and after that nivolumab is given as maintenance every 2 weekly, same dose 3 mg per kg. Next slide, please. So this is again showing almost 80% of patients were having either intermediate or poor risk. Next slide. So what we found, so this result is actually a 4-year update from the same CheckMate 214 trial given by the Albigez L. And what we saw that 1 out of every 2 patients were still alive with this combination. We can see here at the end of 4 years, almost 50% overall survival was there. So that tells huge about this combination. In the sunitinib arm, the 4-year survival was around 35%, almost 1/3, while in half of the patient of this combination were still alive. Next slide, please. If we talk about the PFS curve, at the end of 4 years, 1/3 of patients were still on treatment. I mean, they had not progressed. And if we talk about the sunitinib arm, it was almost 12%. So there was significant difference between the two arms, and the hazard ratio was 0.74. If we talk about the median PFS, it was 11 months in the nivolumab plus EP combination, as against the sunitinib arm, where it was 8.3 months. Next slide, please. So one more thing, that was complete response. Before the era of TKI, or before the era of combination of, actually I should talk about combination of TKI plus IO, we were not seeing this much complete responses. Although as Ravi sir already told, the len plus pembro combination had given almost 15 to 16% of CR rate. Here also we got around 10% of complete response rate, as compared to only 1.4% of complete responders in this sunitinib arm. Next slide, please. This is about the patient who are only in the intermediate and poor risk. Almost 80% of patients were belonging to intermediate or poor risk, and here we saw the disease control rate was almost 42% in the intermediate and poor risk group. Almost 400 patients in each arm were belonging to intermediate or poor risk, 420 patients. So 42% of disease control rate, 42% of CR plus PR, 42% of objective response rate, and 72% of disease control rate. That is huge. Next slide, please. And one more thing, the responses to nivolumab plus ipilimumab are fast and durable. So whenever we give immunotherapy to any patient, there is always a concern of the time to good response, because many a times disease burden is high, and we think about getting delayed responses with immunotherapy. But with this combination, there was faster median time to response, 2.8 months as compared to 3.6 months in the sunitinib arm, and the responses were durable. That is one thing which we have already seen with immunotherapy across the tumor types. Next slide, please. The combination has given a chance of durable survival. We can see here the half of patients were still alive, 50% as compared to 35% in the sunitinib arm. And the durable responses, the 65% of responders at 4 years had ongoing responses. So if any patient achieves good response, either CR or PR, then probability of maintaining it with this combination is very high. So that is one good thing about this combination. Next slide, please. The durability of response, again showing by the swimmers plot. Next slide, please. The treatment-free survival, the time from randomization to second line treatment initiation or death in all intermediate or poor risk patient. We can see here the time since randomization in the Nivo plus EP combination at the end of 30 months or 2.5 years, it was 36% as compared to 16% in the sunitinib arm. Next slide, please. Now talking about adverse event, because whenever we are using something in combination, either it is IO plus IO or chemo plus chemo or chemo plus IO, whatever, we always are concerned about toxicity. We know that toxicity will be more with the combination agent, but here the story is something we can say different. What we think, we can see here the toxicities which are commonly seen with TKIs like diarrhea, fatigue, the hand-foot syndrome, hypertension are obviously more commoner with sunitinib, are more frequently seen with sunitinib. The diarrhea was 28% in the nivo plus EP combination as against 52% in the sunitinib arm. Fatigue was also more in sunitinib, but we know that there are some toxicities which are more commonly seen with immunotherapy, like pruritus, increased lipase level, rash. So these were seen more commonly with this nivo plus EP combination. But if we talk about any grade treatment related adverse event, it was seen almost similarly in both the arms. 94% in the nivo plus EP arm and 97% in the sunitinib arm. Next slide, please. So this is again showing the grade 3, grade 4 adverse events. We can see here, if we grossly also, if we see these charts, we can see that the grade 3, grade 4 adverse event were more commonly seen with sunitinib. Although the side effect profile is obviously completely different in both the combination. In sunitinib, we see hypertension, mucositis, hand-foot syndrome, these things more commonly as against nivo plus EP, where we see immune related side effects like endocrine toxicities, GI toxicities, pulmonary toxicities more commonly. Next slide, please. So the side effect profile, if we talk about the overall side effect profile, total grade 3, grade 4 adverse events were more commonly seen with 64% in the sunitinib arm as compared to 47% in the this combination, nivo plus EP combination. The corticosteroid use was used in almost 29% of patients, and who received actually more than 40 milligram of prednisolone daily to manage side effect profile. The discontinuation rate was the treatment related adverse event leading to discontinuation within 30 days of last dose occurred in 22% of patients in this nivo plus EP combination as against 13% in the sunitinib arm. And the patient who discontinued the either this combination, nivo plus EP combination during the combination phase, were required to discontinue both these medication, because we know that the immunotherapy mechanism is almost similar for both these agents, and the immune related side effects, we discontinue both the agents in those cases. Next slide, please. And we know about how to manage the side effect profile and when to stop the immunotherapy. We know that if a patient develop any immune related encephalitis, or there is inability to reduce corticosteroid dose to 10 milligram prednisolone or equivalent per day, or any grade 2 immune related adverse event, they are persisting despite dose modification, or if patient develops any grade 4 toxicity or any recurrence of grade 3 toxicity. So these are the things where we know that we have to stop the immunotherapy. Next slide, please. We can see here no new toxicities have been identified. We know that even with the single agent nivolumab, we will see these kind of toxicities. There is nothing new with this combination. The number of patients who are getting grade 3, grade 4 events might be more as compared to single agent immunotherapy, but the side effect profile remains the same. The toxicities with the combination have been manageable and reversible using the established algorithms. The approach to management of immune related adverse event is consistent between the combination and single agent nivolumab monotherapy. And the most immune related adverse events improved or resolved with appropriate management, including steroid and or treatment modification. Next slide, please. And the overall survival was not impacted in patient who discontinued combination due to treatment related adverse event. That is one thing, because the durability of response, it is not just about the giving the immunotherapy and seeing the response. Response is long lasting. Even if we have given the dose and patient had discontinued because of side effect, the response has been seen in significant number of patients. So that is one very good thing. Next slide, please. And the early and sustained improvement in health related quality of life, this kidney symptom index, we can see here the if we take a see the graph, we can see here there is significant difference between the two curves. So there was improved quality of life with this combination as compared to sunitinib. Next slide, please. And it was actually first IO combination to demonstrate long-term overall survival benefit with fewer grade 3, grade 4 adverse event than TKI alone. Next slide, please. So based on this trial, the NCCN recommended its use as first line in the intermediate or poor risk groups for advanced clear cell RCC. Next slide, please. So what about patients who are having clear cell RCC with sarcomatoid features? Here also, the combination of Nivo plus EP demonstrated prolonged survival. We can see here at the end of 2.5 years, it was 53% as compared to 29% in sunitinib. Next. If we talk about the objective response rate in patient with RCC with sarcomatoid features, 56% as compared to 19% in sunitinib arm. Next. Here also PFS, we can see there is significant difference, 13% versus 36%. Next. The 30-month overall survival probabilities by number of IMDC risk factors, we can see here the difference between sunitinib and the Nivo plus EP combination is more towards intermediate and favorable risk. And it was not seen in the patient who are having good risk IMDC score. So that's why it has been approved for intermediate and poor risk only. Next slide, please. The objective response rate and complete response rate as per the IMDC risk factors, we can see here in the intermediate and poor risk, we are seeing the response even with these higher IMDC scores. Next slide, please. To summarize, the Nivo plus EP combination is the only IO combination with a chance for durable survival and the durable responses at 4 years. And at the end of 4 years, 1 out of 2 patients in this combination arm were alive. So that is a huge benefit. And the double-digit CR, 10%, which is seen with usually IO plus TKI combination. Here also we got 10% of complete response rate, and the side effect profile also manageable. And the after long-term follow-up of 4 years, the Nivo plus EP combination continues to demonstrate durable efficacy benefit versus sunitinib with manageable safety. Thank you.
Thank you, Amit, for great presentation on nivolumab plus ipilimumab combination. So the toxicities were well described and how to dose modify and when to stop, the acronym champions for that. So thank you very much for that. Now we will move ahead with our panel discussion on advanced RCC. Dr. Akhil Kapoor, who is Associate Professor at Tata Memorial Hospital, Varanasi. He will be moderating the panel discussion. Please welcome Dr. Akhil Kapoor. I would also like to invite the panelist, Dr. Sneha Bothra. She is Consultant Medical Oncology at Mittal Bhilai Hospital, Raipur. Dr. Amit Kumar, Senior Consultant Medical Oncology, Medanta Hospital, Patna. My dear friend, Dr. Tarachand Gupta, Senior Consultant Medical Oncology, Bhagwan Mahavir Hospital, Jaipur. And Dr. Samir Srirangwan, Consultant Medical Oncology, NCI, Nagpur. Over to you, Dr. Akhil Kapoor.
Thank you. Thank you.
Also, I will like to invite Dr. Rajit Chanana. He is Senior Consultant Medical Oncology at Dhanshila Narayana Super Specialty Hospital, Delhi. Dr. Divakar Pandey is Consultant Surgical Oncologist at Sanjeevni CBCC Super Specialty Hospital, Raipur. Over to you, Dr. Akhil.
Thank you, Dr. Siddharth. So I have been given a topic which is a wide spectrum. It will be covering multiple aspects of RCC, and we have a very elite panel panelists available with us. Some of my very beloved seniors and some are dear colleagues. So let's dip into the management of RCC. Let's hope we can get some meaningful insights to this discussion. So this is what we know from a very long time. What is the basis of selection of advanced RCC in actual practice? Dr. Tarachan Boss, how do you select your patient to start treatment? So there are definitely risk stratification is there, affordability and availability of drug is definitely an important point which is looked at. How do you prioritize these things and what things to look at when at which time point?
These questions are very basic questions for starting any treatment in any cancer nowadays. So first of all, I start from the option number 3. So availability of drug is not the issue because of the globalization of the studies and knowledge and pharma companies, MNC. So it is easily available, and if it is not, then can be procured. So second thing is affordability. Yes, this is the most challenging option, and yes, there is one study which is showing that only I think that in immunotherapy drug that less than 5% of our population of our country or cancer patients can afford the higher molecules or the new innovator molecules. So this is the most challenging condition for us. And yes, risk categorization, it is also a matter of then whenever if we have to prioritize between IO versus the IO plus TKI, then it is a matter of the risk categorization. Otherwise, the most important factor goes with the affordability.
Correct. So definitely, there is no single answer to this question. There are multiple answers. The perspectives might change from patient to patient. Even same physician will have different perspective for different patients. So these are the things to be considered. So Dr. Sneha, if you're available, I would like to take your comment. What basic things you do consider in your practice before finalizing the treatment for a patient? Let's consider the patient is a credit patient, railway credit. In TMS, railway credit is considered as the one where we can offer any treatment. So let's take an example of a credit patient where every therapy is feasible. What therapy comes at your back of mind when you're seeing a patient for first line treatment? What things would you look at to decide the treatment? Dr. Sneha, please.
Yes, sir. The first thing actually would be that what is the performance status of the patient?
Okay.
The risk scoring and the performance status of the patient. And considering we are talking about a credit patient, so affordability is not an issue. And after risk categorization, I think now immunotherapy and a TKI combination has become a standard. Now, choosing one of these immunotherapy agents is a difficult task, although Pembro plus Lenva gives a good, a good combination in terms of response rates and in terms of CR, and also that it is effective in all 3 subgroups. Effective in the sense, if you look at the forest plot of that trial, it is the hazard ratio is on the Pembro-Lenva side for all 3 subgroups. So this is one combination which is, my choice of treatment compared to the others.
Okay.
Yes.
So if you have to prefer one treatment out of these in a patient with intermediate or poor risk, you will try to prefer Pembro plus Lenva, correct?
Yes, sir.
Yeah. Yeah. Let's take some perspective from Dr. Samir. Samir boss, are you available for comment?
No, sir. Samir sir is not available right now.
Okay. So let's take on from my dear colleague, Dr. Amit Kumar from Patna.
Yeah. So the key consideration in first line surely the cost is the first thing, and then risk stratification, though we do, but at present what we see for all intermediate and high risk, it is more or less same. We are going with Pembrolizumab, but not affordable might be with TKI single agent cabozantinib is being preferred for the high risk group of patients. But for favorable other, we may go with the sunitinib. So in clear our practice, the most people are not on IOs rather than on TKIs, and we have to just which TKIs to use first is still most important in our setting rather than IO.
Correct. So completely agree. In when we are working in the real practice, 90 to 95% patients will receive single agent TKI in the first line. That is what happens in the real practice as well. However, we need to understand. We'll come to single agent TKI as well because the topic is hot. IO plus TKI, which IO, which TKI, because there are multiple options: IO plus IO, IO plus TKI. Now options for multiple TKIs. So that remains a very important question. Rajit boss, I would like to take your comments. So you have got a patient. The patient is a poor risk patient, multiple sites of disease. Patient has bone mets, liver mets, LFT is okay. What is the best possible treatment you would like to select on a patient?
So I would like to ask you what clinical trial you are running for RCC in first line. So if you are running a clinical trial, then I'll ask the patient to meet you first. Otherwise, see, it basically depends on what is the goal of our treatment. See, sometimes we do get elderly patients, they just want their family, it's not possible for them to take IO every three weekly. Finances is an issue, but logistics are also an issue. So it depends on not only the guidelines, but what the family and the patient actually wants. So if according to guidelines, I would give Lenva plus Pembro as the first line treatment because the response is more. And I would also like to see any high risk features in the histology like sarcomatoid features, rhabdoid features. So then probably Nivo plus Cabo can also be given, but the tolerability of this combination is not good. So either Pembro plus Lenva or maybe Nivo plus 20 mg Cabo. But obviously depends on what the patient wants.
Definitely. These are very, very important and points, and I think that makes real sense in our practice. So moving ahead, let's take comment from Dr. Divakar. Dr. Divakar, for example, you have to select a single agent TKI for a patient. Patient is a poor risk patient. Now you have the option of using sunitinib, pazopanib versus cabozantinib. How will you select the TKI for your patient?
Dr. Divakar is not there. He's a surgical oncologist.
Okay.
So
and Dr. Mohra, okay, Dr.
Mohra is also not there.
Okay. Take care. So then I will come back to Dr. Tarachand boss. Tara boss, again, 3 TKIs available at your disposal. Patient is a poor risk IMDC. How to select between the 3 TKIs?
Usually I give the option that one of my patient, he's also doctor. I ask him that you can go with the best trial, that is a clear trial, which is showing the maximum results. But same time, I explained the probability of the side effects of the lenvatinib in higher doses, 20 milligram. So usually I start with this if the patient is ready to afford these side effects. And the patient was started, and then patient had the hand-foot syndrome and hypertension within 2 cycles. The grade 2 hypertension, grade 2 hand-foot syndrome. Then we came down to the 20 to 10 milligram, and now the patient is doing well. So usually we explain the patient. Otherwise, I opt for the Pembro plus axitinib or nivolumab plus cabozantinib, whatever the choice. Because if the patient is having poor PS, or then I usually go with the cabozantinib because of the that means promptness of the onset of the action, and that is the potency, you can say, of the drug.
Okay. So
I have used in 2-3 patients, and patients miraculously responded to the cabozantinib, and the PS improved from the PS3 to PS1 nearby within 15 days.
Yep. So definitely, we have now a huge experience with sunitinib, significant experience with pazopanib. Now we have early experience with cabozantinib as well. We have now more than 50 patients who have received cabozantinib at TMH Varanasi. We are about to publish that data as well, because this is the largest data from India, where 50 patients have already received cabozantinib. Also, we are running 2 randomized trials in the first line itself, where the patients, we are doing therapeutic drug monitoring for patients on sunitinib, also patient on cabozantinib. We have already formulated a area under curve plot, and we try to optimize the dose. There is a randomized trial for that, which we are running, where sunitinib area under curve is calculated, and we try to optimize the dose based on therapeutic drug monitoring result. Hopefully this trial will complete recruitment by next year and we'll be able to publish our results, because we know cabozantinib is a good drug, but the problem is toxicity. We are all aware cabozantinib is not so easy to handle drug. This is the early experience which has suggested. Dr. Rajat was also highlighting and alluding to the same, and we need to learn how to manage the toxicities. Also, if any better method comes like TDM, it will become a very important standard of care method to manage the adverse effects, so that patient dose can be
one of
adjusted
my
without
patients on cabozantinib is experiencing side effect. Then I switched to from 5 days a week of the cabozantinib. Now the patient is tolerating well and responding also.
Yeah, 5/7 seems to be very useful
So
way
I did
actually.
not change the alternate day. I gave the 40 milligram only the dose. So I did not come to the lower dose. I started on the 5 days a week, giving that holiday of 2 days.
Yes, what I was telling, 5 days out of 7 days for cabozantinib seems to be a very useful method, which we are using as well sometimes when the patient is not tolerating. And we also start usually on 40 mg only, not 60 mg. And then 40 mg, 5 days a week, 5 days on, 2 days off. This is a protocol which we follow when patients are not tolerating full dose. Only then we come down in the next step if patient doesn't tolerate it. In our randomized trial, we get a TDM level at every 3 weeks, where we try to check whether the AUC curve is between that specified level. If that is higher than that, we will reduce the dose. In that, we reduce the dose to 30 milligram. How that 30 milligram? 40 milligram one day, 20 milligram another day. So that will make effective dose of 30 milligram. So these are some of the trials running at our institute, and we are trying to find the best possible way to utilize cabozantinib. Another way, when IO plus TKI is used versus IO plus IO is used. Let's take comment from Dr. Amit. Dr. Amit, for example, if cost is not a constraint, the patient is poor risk, what things you will consider before deciding IO plus IO versus IO plus TKI?
It's only the time in which we want to get the response in this group of patients. So what is the volume of the disease? How symptomatic is the patient? So what is seen if we give a combination of IO plus TKI, if the patient is very symptomatic, may have some early response. Though IO plus IO may have an early response, but the response is slightly delayed with IO plus IO as compared to IO plus TKI. So a high volume disease symptomatic patient, I will consider IO plus TKI as against IO plus IO.
Okay, definitely. So in our clinical practice as well, if the patient is having huge disease burden, patient is very symptomatic, we don't wait to utilize IO plus IO, because we know there will be some patients who will be hyper progressors. Let's take comment. How many patients are actually hyper progressors in the real scenario? Dr. Sneha, your comment for any hyper progressions in IO plus IO or IO alone settings in RCC or any other tumor as well?
So hyperprogressors I've seen in lung cancers. So
Okay.
maybe about 5%, not more than that.
Okay. Any difference in opinion for lung cancer and then RCC?
I have never seen a hyperprogression in last 4 years.
Okay. Great. So extremely lucky. Dr. Siddharth, I will take your comments, the organizer's comment on any hyperprogressor in your experience, or even during TMH training days or your consultancy days.
Actually, honestly, I have also not seen hyperprogression, especially with the combination.
Okay.
I've used it in very few patients.
Yeah,
I have not seen it.
Definitely, with combination, hyperprogression is not an important issue. But as a single agent or IO plus IO, hyperprogression is a thing for which we are actually worried, especially in patients who are having high disease burden, as Dr. Amit has just highlighted. So in that patients where the disease burden is high, patient is having multiple visceral disease, this is one of the criteria which we try to select to decide whether IO plus IO is going to be used or IO plus TKI is going to be used. Some patients ask when we explain the toxicities of IO plus TKI, some patients request not to use TKI if because they don't want to have toxicities. But also IO plus IO is a combination for which immune-related adverse effects are an issue. Any experience with immune-related adverse effect? Let's take comment from Dr. Amit for RCC. immune-related adverse effect with IO plus IO or IO alone, either in first line or second line?
Basically, the endocrinopathies are the most common immune-related adverse event we are seeing. The hypothyroidism is the most common thing. I have few experiences with Addison's disease also. Renal insufficiency are also being seen. So this is the most common. Few patients with pneumonitis too are there. So and rarely transaminitis.
Yeah.
Few patients.
So this is very important. This is the usual sequence and the usual adverse effects, immune-related effects, which we see in our practice. Number one, hypothyroidism, which is very common, can be easily managed. So we are not so worried for it. Just be cautious and do T3, T4, TSH at 3 monthly interval at least, at the time of when you are doing the response assessment. Also, do not forget to do serum cortisol levels at least every 3 months, so that you are aware of timely detection of Addison's disease or any other toxicities. Also, sodium levels are important.
Yeah. How many of the patient have you seen with the Addison's crisis on
Addison
immunotherapy? On immunotherapy.
No. Yeah, crisis is very rare actually.
Then adrenal insufficiency, you can say. That means we are doing serum cortisol, that is okay. But if the every 3 months we are planning, that is the ideal thing. It is the thing different. That is in the trials also. But just I am asking in clinical practice, etc. Because now the concept is which is I am just listening from somebody and come across that even with the rheumatoid arthritis, immunotherapy can be given. I have came across with some oncologist also.
Even with RA, we have a patient who is well controlled rheumatoid arthritis, RA, on methotrexate. We have used immunotherapy in that patient, single agent nivolumab in that patient, because the patient was not willing to take any TKI. So after explaining, after the proper consent, and also if the autoimmune disease is under well control, it can be considered with close monitoring. So it is not a hardcore contraindication now. It is a relative contraindication, but we need to be cautious. And for Addisonian crisis, yes, adrenal insufficiency can occur. We see some patients who develop hyponatremia or other electrolyte abnormalities commonly. Dr. Amit had recently found a case with Addisonian crisis, and we had a detailed discussion. So sometimes these toxicities might occur, but I completely agree. These are not very common. But definitely, if even one patient in your practice develops that toxicity and you have not tested for it, it is also a medico-legal issue. So that is why these patients who are receiving immunotherapy, most of the time, we tend to do as per the protocol. And also, we have analyzed our data of 350 plus patients at TMH or RNC, where we are doing in-house serum cortisol levels, ACTH levels. We have found near about 10% changes in cortisol levels, but only one patient had out of 350 had so low cortisol levels where we required supplementation. The patient was taken consultation from endocrinologist. That was long back. And Dr. Amit has also described a case where cortisol levels were an issue and the patient was managed accordingly. So,
hello,
yes,
hello,
immunity
Akhil.
toxicity.
Hello.
Dr. Samir.
Yeah, sorry. Yeah. Akhil, one point from my side. So you told about hyperprogression. So I had a few patients with hyperprogression, specifically head and neck cancer patient. So in cases where like in hypopharynx or larynx, when you give immunotherapy, this patient already have compromised airway. And in such cases, if there is a hyperprogression, there is a risk of stridor. I have seen one patient of CA larynx. We give immunotherapy second line. He progressed within 1 or 2 cycles. What I remember, he suddenly landed up in stridor. So in that case, you have to be very careful. So because if a patient of larynx or hypertension, you are planning for immunotherapy, and already if you think the airway is compromised, in such cases, it may be better to do a tracheostomy prophylactically, and then give immunotherapy. So avoid such consequences.
Was given single agent or with chemotherapy?
It was single agent second line. That's why.
Single agent second line. Oh.
And in head and neck,
So
you will see more frequent hyperprogressions. Even data, I think data
in
wise
head and neck
hyperprogression is common.
Very It is actually, it might be progression only, not hyperprogression, or it is because natural tempo of the disease is very bad. Even
Yeah,
if use OMCT or even any other treatment, sometimes patient progress really fast and patient
right,
deteriorate
right,
within days. We are
right,
doing a
right. But
randomized, we're doing 3 randomized trials on head and neck cancers presently. So while monitoring the data, I was perplexed to see, do these patients have so bad outcomes? Because initially we think that these have PFS of 6 to 8 months. Then we understand in the trials it was close to 5 months. In real practice, what we see, it is in within 2 months, 3 months, most of the patients progress. A very anecdotal patients, few out of 10, 1 or 2 patients have extraordinary response and these benefit. The problem is that we don't have very good way of selecting these drugs, when to use, when regimen. That is remains a problem. So sequencing is an issue.
right,
Selecting
okay.
the yeah.
Basically, my patient, 2 of my patient had almost no lymphadenopathy, and within a 2 cycle, 1 or 2 cycle, I remember they developed significant bulky nodal disease. So that's why it was like clinically they were not that they didn't have that much of disease bulk at the beginning of immunotherapy, and it was rapid progression. So clinically we suspected that as a hyperprogression, but definitely there is no parameter by which you can label whether it is a hyperprogression or a normal progression without therapy.
Yeah. So moving further ahead, Rajit boss, if the patient has received first line TKI, in the second line, patient is not affordable for IO. Patient receive sunitinib in the first line. How do you decide what TKI to use in the next line? And which TKI is your preference in the second line?
So in the second line, IO is not an option, right? That is what you are asking.
Yes.
So I think you can depend on the histology, clear cell or non-clear cell, and I would use either Cabo or Lenva plus everolimus in the after sunitinib in the second line if IO is not an option.
No.
And I would also like to take your previous questions that IO plus IO combination I think should be only given to those patients who are not who cannot tolerate TKI, like those who have an ejection fraction of 20-30. Otherwise, IO plus IO combination it should not be used. That's what I feel. And second, I've seen polyarthritis also as an IRAE as a side effect, which I managed with steroids.
Okay. So these are good insights and some good experiences which help us as a clinician, and these help to decide. Then I would like to come to again options in the second line treatment. Dr. Amit, a patient receives sunitinib for close to 24 months versus a patient who has received sunitinib for 6 months and has progressed. Will it make some difference in selection of the TKI in the second line in your practice?
Exactly. Surely a patient of 24 months means is a slow growing pace of the disease. But regarding selection of the TKI, it is not, I don't think so. It will be having a much difference. So in both cases, I will be going for lenvatinib in combination with an mTOR inhibitor in both scenarios.
Okay. So there is some difference in our perspective. The patient who has tolerated a TKI for 2 years, that means, as Dr. Amit already highlighted, the patient has a slow growing disease and has good sensitivity to VEGFR. So in that patient, it is my preference to use exitinib in that patient. It is one of the very well tolerated TKI. But if patient has progressed on 6 months, I would be aggressive and try to use Lenva plus everolimus versus cabozantinib, any of the two. Mostly Lenva plus Evro, as our data is now more than 70 patients on Lenva plus Evro, and we utilize Lenva dose of 10 milligram starting dose and escalate up to 14 mg. So this is a point which we try to see. The progression-free survival on sunitinib or pazopanib help us to select the next line treatment as well. But I agree, in patients who have aggressive disease, definitely Lenva plus Evro versus cabozantinib is our choice in most of the patients.
So the
Any
rationale
comment?
behind using
Yeah.
exitinib post indolent is
Yeah, exitinib is a well-tolerated drug, and there is data to utilize exitinib post sunitinib. It is also a VEGFR TKI. When VEGFR is acted well for 2 years, it makes sense to utilize another VEGFR TKI when the patient has already a good tolerance and good response for 2 years. So that is a basic premise, and it can be considered. But definitely in patients who have progressed earlier, we try to utilize another mechanism of actions. This is, I'm talking about when the patient is not affordable for immuno. Immuno is usually the preferred second line treatment if patient has received TKI. But again, in patients who are affordable, Nivo plus cabozantinib can be used in second line treatment as well, because there is significant risk of hyperprogression as well, especially in patients who have significant disease burden. Dr. Sneha, I would like to take your comment. In second line treatment, post TKI in first line, would you consider single agent Nivo plus use single agent cabozantinib versus Nivo plus cabozantinib if fund is not an issue?
So post first line failure, I think a combination would be a better option if the PS allows, if the performance status is good enough that he can tolerate immunotherapy. Because to my experience, wherever we have used immunotherapy in poor PS patients, we have probably caused progression rather than having some response. So basically, if PS allows, then yes, combination.
Yeah. So because these patients who have progressed on the first line, there is some chances that patients can progress really fast. And if the disease burden is high, we'll be happier to use a combination in this line. Dr. Siddharth, boss, do you agree with this comment, or you want to make any other comment?
No, I agree with the comment that if any patient has progressed early on TKI, then I would like to consider for a more aggressive treatment, and probably a combination logically will fit in that.
Yeah.
One thing I want to ask from my ask is that the lenvatinib dose that you have commented, you are using it 14 milligrams. So I am not very lucky in that I'm never able to escalate more than 8 milligrams. So lenvatinib, is it tolerable in patients, especially in combination with pembrolizumab?
Lenva plus pembro, yeah. Pembro plus lenva, we have also seen some toxicities. Initially, we thought this is one of the preferred combination based on responses, but yes, I agree. Pembro plus lenva, when we have used, we have found more than 10 milligram very difficult to use. 10 milligram Lenvima is our preferred choice. There is also difference in the response toxicities based on whether using innovator versus generics. This we have come across very frequently, because we have a significant number of patients who are on innovator brand versus generic. Here I have found that there is significant difference in toxicities for innovator versus generics. With the innovator molecules, we have found that it is somewhat better tolerated, while generics have significant amount of hypertension and increased HFS and transaminitis. This is what has been my experience. So with the availability of support programs in the innovator as well, I try to utilize innovator molecule in my practice wherever feasible, because this makes some difference in my practice, which I have found in my experience. Any comment on innovator versus generic lenvatinib, if anyone has any experience or comment to share? Dr. Rajit Bose or anyone else? Doesn't seem that anybody wants to comment on that.
Yeah, using in one patient Lenvima, but I don't know how to differentiate, because I don't have the just comparative patients also, because on the same indication one in but the patient experience within 2 weeks the grade 2 hypertension patient was become on 2 drugs of the antihypertensive, and TSH become more than 100 at around 105 something, and there was a triglyceridemia also there, and Handfoot syndrome was also there. But the dose at the same time dose was 20 milligram. But when the dose brought down to the 10 milligram, all these are settled nearby. Only the hypertensive patient now on single agent antihypertensive. So I have no comparison arm, but yes, I am using them.
Okay. So I have only 1 minute remaining. This is one of the meta-analysis which has shown various combinations which can be used in the first line. But despite being a meta-analysis, we know that these don't have direct comparison with each other. It is very difficult to use, and Pembro plus XZ, we have our maximum experience. It seems to be a good option. Atezo plus Bev, we definitely not use this combination very frequently. Avelumab plus Axitinib, there is some experience now, but this also is not very frequently used. Nivo plus Epi, we now have experience of more than 10 patients. We have experience of using Pembro plus Lenvatinib. In my experience, Pembro plus Lenva gives very good responses, but toxicities is a problem. So in patient who's very fit, young, I would like to use Pembro plus Lenva, but otherwise we try to use Pembro plus Exi, or in patients with lower disease burden, I try to use Nivo plus EP. So this is what is our experience and conclusion. If there's any other point which we want, any panelists want to discuss, or Siddharth boss wants to discuss, we can take it, else I will stop here.
Sir, I have one question. With the coming up trials of low dose immunotherapy, what do you think? Where will that fit in? As in, because TKI is usually it's TKI. So
Actually, we are using Nivo plus cabozantinib, Nivo in low dose in a lot of patients in second line treatment. In the first line, we don't want to use low dose because it is difficult to explain when there are so many options. Why do you want to utilize low dose treatment? In the second line, we are using a significant number of patients on low dose nivolumab plus cabozantinib, and our data is now more than 25 patients in RCC. Let's see whether it is making some difference. It's a 40 milligram monthly dose.
40 milligram. Okay, sir.
Monthly dose, yes. Whether it is making a significant difference, we don't know, because data remains anecdotal. We won't have a randomized trial in this setting, it seems, but I think as there was a randomized trial at TMH for OMCT plus low dose Nivo, hopefully, because we have a huge loss burden of RCC, we might be able to do a second line trial, at least low dose Nivo versus cabozantinib alone. Hopefully that might be carried out in our setting.
In first line, if full dose immunotherapy is not affordable, would you choose low dose versus would you choose low dose or no immunotherapy?
So that depends. For example, if you want to use cabozantinib in the first line, adding low dose Nivo might be an option, because if you want to use sunitinib or pazopanib in the first line, then we don't have any data of combination with the immunotherapy. Right. That is why low dose Nivo plus cabozantinib. But still, we try to utilize low dose Nivo in the second line, because cost is an issue in the first line, and we know the patients will have a PFS of at least 8 to 10 months usually. So low dose Nivo will also be an issue in the first line, the cost wise. So in the second line, we know the PFS is somewhat lower, 4 to 5 months maximum most of the times. Then low dose Nivo might add, and it won't be a problem usually. That is the premise on which we use in the second line, not the first line.
Right. Thank you.
Thank you for the excellent discussion. Back to Siddharth sir.
Thank you, Akhil, for having such a nice discussion on RCC, covering every aspect of it. And now I would like to invite Dr. Satyadev Sharma. He is a consultant urologist at Radiant Super Specialty and Cancer Hospital. He will be talking on evaluation and management of non-muscle invasive bladder cancer. Over to you, Dr. Satyadev Sharma.
Yeah, thank you. Thank you very much. At the outset, I would like to thank the organizers for involving me in this talk. I think I'm audible, and I want to share my screen. Is this visible there?
Yes, it is visible.
Okay. So good evening all. My topic is evaluation and management of non-muscle invasive bladder cancer. Myself, Dr. Satyadev Sharma. I'm a consultant urologist at Radiant Super Specialty and Cancer Hospital, Raipur. So just an overview, how the patient presents to us and how it is evaluated, how he or she is evaluated, investigations, basic diagnostic histopathology reports, classifications, high-risk group stratifications, what are the treatment options available, how we follow up, and what the current guidelines say. So a suspect of non-muscle invasive bladder cancer, or per se urinary bladder mass, present to us with hematuria, lower urinary tract symptoms. Mainly when you suspect urgency, frequency, then these are indirect signs that he may be a suspect of CIS, means carcinoma in situ. History of passing tissue bits in urine or recurrent UTI or acute urinary retention, and he may or she may be asymptomatic, incidentally detected on ultrasonography or CT done for any other purpose. So the basic evaluation starts with a good clinical history taking, which includes high risk factors like age, smoking, exposure to chemicals, and pattern of hematuria is very important, whether it is initial, it's terminal or total, whether it is associated with pain, clots, passing of tissues. For example, hematuria from bladder is typically gross, means whole of the urine is red. It is total, painless, and clots are amorphous. They may be of any shape. So physical examination is usually unremarkable in non-muscle invasive bladder cancers, but sometimes there is a loss of blood. So facial edema, pedal edema, or sometimes acute urinary retention because of clots, palpable bladder, and DRE is must for completion of genitourinary examinations. So our next basic step is urine routine and microscopy, in which proteinuria, RBC morphology, cast, sediments, these should be looked at. For urine analysis, the urine should be freshly voided. It should be midstream. It should be clean catch, and it must not be the first morning sample. So apart from screening ultrasound of kidney, urinary, bladder region, if there is a suspicion of lower tract lesions, then directly we can go ahead with cystoscopy and proceed. And for waiting for CT report is not advisable. If there is a upper tract lesion concomitant or suspected, then CT urography is mandatory. Urine cytology for malignant cells should be performed in freshly voided urine, and urine sample must be 25 ml at least, and it must not be the morning sample. And sometimes in case of a hematuria, it is very difficult for pathologists to report the urine cytology report by Paris classification. So it is recommended that use of a glacial acetic acid for hemolysis of RBC, and then we can go ahead with the urine cytology report. So then if there is suspected malignancy or mass lesion, then cystoscopy is mandatory, and it cannot be replaced by any non-invasive test like urine cytology or bladder tumor antigen or NMP22 or Eurovision, which is available but less commonly utilized. So cystoscopy is followed by TURBT, that is transurethral resection of the bladder tumor. And these are the latest EUA guidelines that recommend about the complete history taking, renal and bladder ultrasound followed by CT urography during the initial work of a patient if he or she presents with hematuria. If the patient doesn't present with hematuria and incidentally bladder tumor is detected in ultrasound, then performing a CT urography can be deferred after TURBT also. So the basic classification of muscle invasive, non-muscle invasive bladder cancer depends on the presence of the detrusor muscle invasion. That is the main crux during TURBT. So when we perform a TURBT, whether it is from a rigid or flexible scope, whether it is a white light, blue light, or narrow band imaging, whether it is bipolar, monopolar, or laser, actually these things doesn't matter much unless you have a clear sample for histopathology, which includes the deep muscle sample. So in the right side of the picture, you can see there is a papillary intravesical growth in the figure A. In the figure B, the superficial chips has been removed. In the figure C, we can see some muscle segments is there. And in the figure D, we can see that there is a glistening perivesical fat. So this is the complete sample that we require. It must contain the detrusor muscle. So sometimes we also need to take some random biopsy or the bladder mapping biopsy. These are required when we are suspecting a carcinoma in situ, or we are doing a re-TURBT for T1 tumors, or for we are doing a re-TURBT and we are planning for neobladder or early cystectomy. Then these random biopsies are also needed. So histopathology report, that is the anchoring point of our diagnosis, that must specify the tumor location, tumor grade, lymphovascular invasion, any sort of variant histopathology, presence of carcinoma in situ, and presence of detrusor muscle in the sample. So these are collective points from all the guidelines, whether it is NICE guideline, EUA, AUA, every guideline mentioned that these points are mandatory. So sometimes we need to repeat biopsy or repeat the TURBT. So what are those conditions? And precisely saying, the repeat biopsy is of 3 types. It may be re-TURBT, that means bladder mass was large, and during the procedure, because of bleeding or because of a patient jerk and all these things, we cannot complete the procedure, or there is a doubt of completion of all the tumor segments. So again, we have to do the TURBT, that is called re-TURBT. Another term is restaging TURBT, means there is no muscle in the specimen. And then we do restaging TURBT to include the detrusor muscle in the specimen. Another term is second TURBT, which is to be done after T1 tumor. There is a risk that there may be upstaging. Then we do this TURBT. So whether you do it by monopolar, bipolar, it doesn't matter much. If you are removing the tumor en bloc, then it is good. But removing a large en bloc tumor per urethra is itself a difficult. And if we require morcellation for removing the specimen, then there is no use of removing it en bloc. So our basic classification that has already been dealt in the previous slides, but just T1 stage I will cover. T0 means no evidence of primary. TA is non-invasive papillary carcinoma. T is carcinoma in situ or the flat tumors. T1 is tumor which is invading the subepithelial connective tissue, but not the detrusor muscle. If it involves the detrusor muscle, then it is T2 and called muscle invasive. So this is the latest EUA risk stratification, and it has included 3 new points, which are called as additional clinical risk factors. First one is the age, more than 70. Second is multiple papillary tumors. Third is tumor size or diameter more than 3 centimeter or 3 or more centimeter. So depending on these, previously there was only 3 risk groups: low risk group, intermediate risk group, and high risk group. But in the recent classification, they have included very high risk group. And this very high risk group is intentionally sub-demarcated because this risk group treatment requires early radical cystectomy, which was earlier not considered as a part of treatment for non-muscle invasive bladder cancer. So even in the intermediate risk group, many of the guidelines, they have mentioned the 4 important factors: whether they are multiple tumor more than 3 centimeter, early recurrence, or frequently recurring tumor. And depending on that, they have also sub-stratified intermediate risk also. So this risk stratification, all patients with carcinoma in situ in the prostate urethra or variant histopathology or lymphovascular invasion, these should be categorized into very high risk group. And patient with recurrent tumor should be included in the intermediate, high or very high risk group according to their prognostic factors. So what is the basic for treatment and follow-up? Since there is a considerable risk for recurrence and progression of the tumor after TURBT, adjuvant therapies, usually adjuvant intravesical therapy, is recommended for all stages. And intermediate single post-operative installation of chemotherapy after TURBT that can reduce the recurrence rate in patients with low risk and selected intermediate risk tumors. And further chemotherapy installation can improve recurrence-free survival in intermediate risk tumor, but they do not prevent progression. Only thing that can prevent progression is BCG therapy and not the intravesical chemotherapy, because intravesical chemotherapy is given only to prevent the tumor seedling. When we do TURBT, there are tumor cells, they are floating in the bladder. To prevent tumor seedling and recurrence because of those floating tumors, intravesical chemotherapy is useful, but per se for preventing the progression of the disease, chemotherapy intravesical is not useful. It is only the BCG therapy that can be immunomodulatory. So intravesical immunotherapy with BCG induction and maintenance is superior to intravesical chemotherapy in reducing the recurrence and in preventing or delaying progression to muscle invasive cancer. So what are the treatment options for non-muscle invasive bladder cancer? These are after TURBT, intravesical chemotherapy or intravesical BCG therapy, or when there is a follow-up, during follow-up cystoscopy, if there is progression or recurrence, then early radical cystectomy. And if the patient is not fit or refuses early radical cystectomy, then chemohypothermia with mitomycin or sequential gemcitabine and IV pembrolizumab. This is the new finding. They have in the very high risk category, if the patient is not fit for early radical cystectomy or refuses, then only one drug that can be given IV is IV pembrolizumab. This is from Keynote 057 trial. So intravesical chemotherapy, it may be given immediately with mitomycin, epirubicin, or gemcitabine within 6 hours. Adjuvant, it may be adjuvant therapy in the form of mitomycin 40 mg 6 weekly induction cycle and then monthly maintenance till 1 year. We should optimize the pH, urine volume, and for improving the efficacy of chemotherapy, electromotive, hyperthermic, and microwave-induced therapies can be given. So basic regimen for intravesical BCG is induction regimen in which 80 or 120 mg onco-BCG is given, usually to make a balance between the toxicity and effectiveness. Usually nowadays 80 mg onco-BCG weekly for 6 weeks is given as induction, and 80 mg onco-BCG 3 weekly for maintenance. And for intermediate risk, 1 year maintenance is given. For high risk, 3-year maintenance regimen is given. So when after giving BCG also, during check cystoscopy, if there is a recurrence or progression from low grade to high grade or from TA to T1, then this indicates that the BCG therapy is not going to be effective. And then we label it as BCG unresponsive, for which treatment option is early radical cystectomy or enrollment in the clinical trial for bladder preserving surgeries. So what is the rationale for early cystectomy in non-muscle invasive bladder cancer? That is 50% patient with very high risk, they progress to muscle invasive bladder cancer over 10 years. So this is a very high risk category. That's why they have risk stratified into very high risk category. There is an improved disease-free and overall survival. That is 90% overall survival at 5 years. If the early cystectomy for very high risk non-muscle invasive is done, as compared to the deferred cystectomy, which is done after recurrence. And also the 10-year cancer specific mortality, that is less when early cystectomy is done for non-muscle invasive bladder cancer. And approximately 25% of the patient or the sample of radical cystectomy, they are under stage. After radical cystectomy, the histopathology shows that whatever the grading and staging was done during TURBT, that was under stage. So these are the recommendations from EUA guideline that in patients with very high risk tumor, non-muscle invasive, we should discuss radical cystectomy. And if the patient refuses, then other therapy of bladder preservation should be followed. So in low risk, there is a recommendation for one immediate intravesical chemotherapy after TURBT. In intermediate risk, all patient either should receive BCG for 1 year or full course 3 years. For EUA high risk, BCG therapy for 3 years. For intermediate risk, BCG therapy for 1 year only. For high risk, BCG therapy for 3 years. And for very high risk, we should offer early radical cystectomy or intravesical full dose BCG for 3 years. Or if the patient is unfit, then other bladder preservation. So what is the follow-up? Follow-up for low risk, usually follow-up should be done by cystoscopy, that is a gold standard, along with cytology and sometimes CT-IVU. If there is a low risk, then at 3 months and 12 months, and then annually till 5 years, cystoscopy should be done. For intermediate risk, 3 monthly, then 6 monthly till 5 years. For high risk, 3 monthly till 2 years, and then 6 monthly till 5 years. And for very high risk patients, CT-IVU and cytology should also be done at follow-up. EAU guidelines recommend lifelong follow-up for high-risk patients. So summarizing the key points, complete initial TURBT of all visible bladder tumor is essential, and an early repeat resection means we should have low threshold for repeat TURBT. Whenever we feel that a sample is inadequate or there is a very high risk for progression. Patient should be risk stratified according to the pathology, clinical history, and response to intravesical therapy. The follow-up of non-muscle invasive bladder cancer should be based on the regular cystoscopic surveillance, because there's a high risk of recurrence and progression. And non-invasive tests such as urinary biomarkers, that should not be replaced by cystoscopy in the surveillance. So in the low-risk non-muscle invasive bladder cancer, after TURBT, single immediate mitomycin or epidurobicin therapy. In intermediate risk non-muscle invasive, after TURBT, intravesical chemotherapy or BCG for 1 year. For high risk non-muscle invasive, after TURBT, intravesical BCG for 1 to 3 years, or radical cystectomy should be considered. In very high risk non-muscle invasive bladder cancer, early radical cystectomy or intravesical BCG for 3 years should be done. And if the BCG failed or patient is unfit or refuses for radical cystectomy, then options are limited, which are chemo, hypothermia, mitomycin, intravesical sequential gemcitabine docetaxel, and IV pembrolizumab. So thank you for non-muscle invasive bladder cancer. This was a short summary.
Thank you very much, Dr. Satyadev, for a talk on non-muscle invasive bladder cancer and summarizing the EU guidelines and providing the indication for HCG, the role of intravesical chemotherapy, and the need of indications of radical cystectomy in very high-risk patients. Now, I would like to invite Dr. Yashwant Kashyap. He is a consultant medical oncologist, assistant professor at AIIMS Raipur. So he will be presenting on the role of Amilimumab in metastatic bladder cancer. So this is a sponsored session by Merck. Over to you, Dr. Yashwant Kashyap.
Thank you, Siddharth sir, for giving me opportunity. Geetika, can you please?
Can I share from my side or your side, sir?
No, I will share.
Okay, sir.
My slides are visible?
Yes, sir.
Siddharth sir, my...
Yes, visible.
So, thank you, Siddharth sir, for above conference. I have seen Tara Boss after 4 years, I think. So today I will discuss about evolving trends in management of metastatic urothelial carcinoma. My slides are moving now.
Sir, can you please screen your Zoom?
Full screen only.
Your screen is moving. Can you please full screen?
Full screen only.
Yeah.
Sir, slides are moving.
Yes, your second slide is visible, sir.
Okay. So today I will discuss about management of metastatic urothelial carcinoma. Dr. Amit has already discussed about neoadjuvant, adjuvant, and Satyadev sir has already discussed about the role in non-muscle invasive bladder cancer. So I will discuss about metastatic. So we know that bladder cancer are 10th most common cancer, and amounts for around 3% of all cancer diagnosis. Most common histology is transitional, but we have seen adenocarcinoma also commonly. So, incidence is around 440,000 per year. It's the 6th most common cancer in men. In India, it's 17th most common cancer. Histology is transitional, and 5-year prevalence is relatively high in a smoker group. So in this, median age is around 60 years. In a smoker, in males, incidence is around 8.9% higher compared to female patients. This was the study done in 2013 in Tata Memorial Hospital, where we have seen the out of 419 patients, around 47% were non-muscle invasive cancers, 35.7% were muscle invasive, and 17% are metastatic patients. But I think in our experience, this metastatic subgroup is slightly higher. Maybe we are in more group. So, treatment of urothelial carcinoma is changed markedly. From earlier in 70s, only cisplatin was the option. Then came Amvec. Then came other platinum-based therapies. Then in 2008, gemcitabine. But we know that with advent of immunotherapy, profile of our patient has changed markedly, and with maintenance therapy with avelumab, which I will show in further slides, things have now changed markedly, and it is now a standard of. It is a very aggressive disease, and median survival, what we have seen in our practice, it is generally less than 1 year, even with available therapy. And many patients, why we have to incorporate other maintenance therapy, which I will discuss that they are benefiting, because around 40% of our patients, after progression, they are not fit for second line therapy. So most of our patients are cisplatin eligible,
but your PPT slide is not moving.
So please, you start share.
Hello.
Vidika, please, can you share
Yes,
on my
just a 1 minute, I'll share.
slide number 9, Vidika.
Wait, sir.
Please make it full. Okay. So in first line PFS, most of our patients respond to chemotherapy well, though these responses are not durable. Around 80% of our patients respond to this therapy, and then after some time, after 2-3 months, they almost always require second line therapy. So overall, median survival is around 14 to 15 months only. In metastatic setting, carboplatin and cisplatin difference is not much. So generally, due to better toxicity profile, we prefer carboplatin. But in young fit patient, cisplatin should be offered. Next slide. So this was the approach. So then after I will show in further slide why this concept of switch maintenance and further therapy came. Because in various continuation of IO with chemotherapy trials, it has not shown that much benefit. Next slide, please. So in this, our goal is that our patient should live longer with good quality of life. So in various trials, as immunotherapy has come markedly like in other cancer, here also they were tried in combination with chemo, atezo plus platinum-based chemo. It has not shown significant OS difference. Similarly, in Keynote 361, Pembro plus platinum-based therapy has also it was also a negative trial. Durva plus for second immuno drug was therapy was also a negative trial. Next slide. Then as there is concept that with immunotherapy after exposure of chemo, some newer antigens are exposed, which leads to our drug working better. So this which concept of switch maintenance came. So in patient who are responding to our first line platinum based therapy, they were given maintenance with immunotherapy drug avelumab, which was done in Javelin 100. Next slide. So now the standard of practice is switch maintenance. To give first line chemotherapy for fixed induction of 4 to 6 cycles. Then in patient who are CR, PR or stable disease, we stop chemotherapy. Then we start our maintenance therapy with avelumab therapy. Then when this patient progress, we give them second line chemotherapy or other therapy. Next slide. Rationale for immunotherapy, because platinum-based chemotherapy has direct cytotoxic effect, which leads to decrease in tumor burden, and they also prime the tumor for immune check inhibition therapy. So that's why the now standard is first line maintenance with avelumab till progression of disease. Next slide. So, today I will discuss about Javelin bladder 100 trial. Next slide. In this trial, it was phase 3 randomized open label study. Patient in this trial, unresectable, locally advanced or metastatic urothelial carcinoma with a stage 4 disease who have received standard first line chemotherapy 4 to 6 cycle with cisplatin plus gemcitabine or carboplatin plus gemcitabine. After a patient having radiological CR, PR or stable disease, they were randomized. Treatment-free interval was around 4 to 10 weeks from last chemotherapy cycle. And there were 700 patients, and out of which 51% patients were PD-L1 positive. And then they were randomized in two arms, avelumab 10 mg per kg every 2 weekly, plus best supportive care versus best supportive care alone. 350 patients in both the group. Primary endpoint was overall survival, and secondary endpoint was PFS and overall response. And they were stratified based on response and metastatic sites. Next slide, please. So it is phase 3 randomized open label with on 370 arms, including India, 700 patients, locally advanced or metastatic urothelial carcinoma, given avelumab plus BSC versus BSC as first line maintenance therapy after platinum-based chemo. Next slide. Median age was 68 years. 76% were male, 24% were female. ECOG was 0 to 1, 0 in 61% and 39% had ECOG of 1. Then location of visceral mets were around 55% patient had, non-visceral was on 45. And in chemotherapy regime, around 52% patient have received cisplatin-based chemo, 42% had received carboplatin-based chemo. Next slide. So in this investigator assessed PS, overall population, there was more than 2 years of median OS and more than 2 times PFS compared to best supportive care alone. And this curve started separating earlier. And median OS in avelumab arm was 23.8 months compared to only 15 months in BSC arm. and it was significant. PFS was 5.5 months compared to 2.1 month only in BSCM. Right. Geetika, next slide, please. And in this group, around 50% of patients in avelumab arm progress after CR, whereas in BSC arm, 77% patient progress. Similarly, in PR group also, avelumab has benefited the patient by decreasing progressive disease. Next slide. Based on response to first-line chemotherapy, patient who had CR post-chemotherapy, they had median OS of 39.8 months compared to 26.8 months in BSC alone. Whereas in PR arm, it was 19.2 2 months compared to 12.8 months. In stable disease arm, it was 22.3 months compared to 14 months in BSC alone. So patient who had CR, they have done very well with avelumab, though there was a benefit across all groups. Next slide. PFS was also better in avelumab arm compared to BSC alone. Next slide. So, safety, though there were 23% around toxicity in avelumab arm, but they were, I will show in further slide, they were manageable. Next slide. Most common side effects were like Rajat sir told, arthralgia, pruritus, and these were the common like other immune drug like side effects. And though grade 3 side effects were higher, but they were manageable, which I will show. Next slide. Around 50% in BSC alone now, 74% around patient received second line chemotherapy, but in avelumab around 50% patient received second line chemotherapy or any other immune directed. Next slide. So to summarize about sequencing in avelumab arm, out of total 700 patients, there were 350 patients who were in avelumab arm, out of which still 43 patients are receiving avelumab. Out of 307 patients have discontinued. We have discontinued. They have discontinued avelumab, and out of 307, around 1/3 patient have not were not able to receive second line therapy due to various reasons. Whereas in second line, other 2/3 patients, they have received platinum-based chemotherapy and other immunotherapy and other anti-cancer. Next slide. So OS was almost even after discontinuation. It was almost similar, around 18 months in across all the. Next slide. Out of at end of out of around total 350 patients, around 200 patients, around 150 patients have received second line chemotherapy. Next slide. So this is the subgroup analysis of Javelin bladder trial. Next slide. Out of total 700 patients, there are 147 patients who are from Asian population, out of which 73 were given randomized into avelumab side and 74 were BSC alone. And primary, we will analyze this subgroup. Primary endpoint was OS. Next slide. In baseline characteristics were almost similar in both the groups. In all the next slide. median, it has shown Evolumab has also prolonged the benefit and increased survival in Evolumab group compared to BSC alone, with median OS of 25.3 months compared to 18.7 months in BSC alone. And PDL1 population also have benefited compared to BSC. Next slide. It has also delayed the next line chemotherapy in Asian population of 14.8 months compared to 9.2 months in BSC alone. Next slide. Responses were also doubled, almost doubled in Evolumab arm compared to BSC alone. Next slide. So there was a higher toxicity, both grade 1, 2, and 3 in Evolumab arm, and also there were around 20 patients who had immune-related side effects. Pyrexia, rash, constipation, and nasopharyngitis were common side effects. Anemia was the major grade 3 toxicity in this Evolumab. Next slide. Regarding guideline updates, next slide. Due to all of this, Evolumab maintenance is now recommended for all platinum eligible patients, whether they are receiving cisplatin or carboplatin, and irrespective of PDL1 status. So now, across all the guidelines, it is first line recommendation for both carboplatin and cisplatin group who have responded to first line of chemo. Right. So regarding the second line therapy, we have further options of giving re-challenging with chemotherapy, or like Dr. Akhil, Dr. Amit told, N42 is also option, and in post platinum we can give Pembro Evolumab as second line. Next slide. So now things have changed. Earlier we used to counsel the patient that median will be around 1 year, but things have changed. PFS, OS both have doubled, and now switch maintenance is way to go. Adding that treatment-free interval of 4 to 10 weeks, the overall survival will roam around 30 months. Next slide. Which is almost a doubling of PFS. Next slide. OS with Evolumab maintenance compared to giving chemotherapy alone. Next slide. Next. So to conclude, long-term follow-up Javelin bladder 100 trial, you can see that it has prolonged median OS, PFS in compared to BS. In overall, median OS was around 23.8 months compared to only 15 months in BSC alone. At 2-year OS was 49.8 months in Evolumab arm compared to only 38.4 months. Yeah, PFS was also tripled in Evolumab arm, and though there were even though most of the patients after Evolumab have not received further chemotherapy, but still OS was prolonged in that arm. And so safety was also demonstrated, and there was a low discontinuation rate due to treatment-related adverse effects. Thank you.
Thank you very much, Dr. Yashwant, for summarizing the data on metastatic urothelial cancer. So you have very well presented that among all the strategies, it is the maintenance, switch maintenance with Evolumab post platinum based chemotherapy, which has the greatest overall survival. And I would like also to add to that, in the second line, if patient has already received chemotherapy and has a significant chemotherapy free survival, then we can re-challenge with the same chemotherapy. And the other option, the most data is for enfortumab vedotin, which can be given. There is also a phase 2 trial of an immune checkpoint inhibitor along with enfortumab, which can become a future standard of care in cisplatin ineligible patient. So now I would like to invite Dr. Rushabh Kothari for a panel discussion on metastatic bladder cancer. I would also like to invite the esteemed panelist, Dr. Pradeep Chandrakar sir. He is professor at Regional Cancer Center, Raipur. Dr. Rajiv Ratan Jain, he is also professor at Regional Cancer Center, Raipur. Over to you, Dr. Rushabh Kothari.
Thank you, Dr. Siddharth, for this opportunity. All the panelists are there, I think, online, no?
Yes, Dr. Ravi Jaiswal, Dr. Yashwant Kashyap, Dr. Rajiv Ratan Jain, everyone is here.
Okay. Can you please share a slide from your side? So, meanwhile, Dr. Yashwant has covered the topic pretty well. Majority of the things which I intended to discuss has been already shown by him. So we will try to concentrate more on question answers rather than the theoretical discussion. Geetika, if you can share the slide, please.
Yes, sir. So can I share from my side?
Yes, yes. Please share from your side.
I would request Dr. Amit Agrawal and Dr. Satyadev and Dr. Tarachand also to chip in. And Dr. Amit Kumar, if possible, please be a part of active discussion.
Okay, so by the time we have the slides on, we'll just like to have a gross idea how we all practice versus what the guidelines are. Okay, so for any metastatic urothelial carcinoma of bladder, we define the patient either whether patient is cisplatin eligible or not, and whether patient is platinum eligible or not. Next slide, please. So, what is your general take? What are the percentage of patients who are cisplatin eligible? Percentage of patients who are not cisplatin eligible but eligible for other platinums, and the patients upfront who are not platinum eligible. One is as per guidelines, and second is what is in your routine practice. So I wanted to know what it is in your routine practice. Can you start with Dr. Rajiv?
Mute myself. Hello.
Hello. Hi, yes, we are able to hear you.
Yeah. We generally see most of the patients are, significant number of patients are cisplatin ineligible, but there are some young patients who are cisplatin eligible patients. Mostly, so we go for gemcitabine carboplatin. Cisplatin
okay.
is less.
Okay. Dr. Pradeep, any other opinion?
I think he has left. So
okay. Dr. Suman?
Ma'am is not there.
Okay. Dr. Sneha?
She's also not there.
Okay, so we have Dr. Rajiv, Dr. Ravi, Dr. Siddharth, Dr. Yashwant.
Yeah.
Okay, so Dr. Ravi, if you can give a ballpark figure regarding cisplatin eligible, cisplatin ineligible, but platinum eligible, and platinum ineligible upfront.
So I think 50 to 55% will be cisplatin eligible, and 20-25% would be cisplatin ineligible but carboplatin eligible, and similarly 20 to 30% would be platinum ineligible. That is what I see in my practice.
Okay. And Dr. Yashwant, say for example, patient has borderline GFR. So do you modify the regimens, say do cisplatin day 1, day 8, carboplatin day 1, day 8 instead of day 1? Or you would label them ineligible and move to the next category?
In such case, I will generally prefer carboplatin. And I will in adjuvant setting, some neoadjuvant or sometime I have done about day 1, day 8. But in metastatic setting, in such case, I will prefer carboplatin.
Okay. So the idea, what I'm getting is that many patients are cisplatin eligible and majority are platinum eligible, maybe cisplatin ineligible, where we will try to give carboplatin. And there is a small chunk, but obviously around 20% or so, who are not platinum eligible. We try to give carboplatin in such patients. If we are able to give, maybe we will split it day 1, day 8, we will dose modify. And in spite of all this, there will be a chunk of patients who are platinum ineligible at all. Next slide, please. So, Dr. Siddharth, what is your definition of platinum eligible? Do you go by what the guidelines are?
So
Next slide, please. You can do that.
don't
Next slide.
very strictly follow to that 5 criteria because if many of the patients will not come to cisplatin eligible, we strictly follow those criteria because most of the patients are elderly. So ECOG more than equal to 2, I think more than 60-70% will be patients cisplatin eligible. But that is not clinically true. Many of these patients tolerate cisplatin very well.
True. So,
so the strict criteria for me is NYHA heart failure, ECOG performance status 2, and creat clearance less than 30 ml per minute. So these are like the strict criteria. And for the others, it is like subjective based on the other things that is there.
True. So any other opinion from panelist, Dr. Ravi, Dr. Rajiv, or Dr. Yashwant? If you have any other opinion, please chip in.
I think the criteria is easy to be followed. It's not like you need to do something. It's a clinical criteria. And
No,
I don't know, we don't need bladder, but I follow this criteria and I kind of stick to this. I mean,
no, so suppose the question is, suppose someone's create clearance is 55, you would not give cisplatin to them. Based on this criteria, patient is not cisplatin eligible.
I agree with you, Dr. Rishabh, but I think more or less I follow this criteria. That's what I'm trying to tell you.
Okay. So,
Dr. Rishabh,
yeah,
I want to add something. Like, if suppose your patient is with mild or moderate obstructive uropathy, and then his creatinine clearance is not that low. So, what do you do with that?
So the first thing is that this create clearance has to be the corrected one. So if there is some obstruction and hence create is high,
there is some obstruction, like there is mild, moderate hydronephrosis.
So if there is hydroureteronephrosis or something like that, which is leading to increased creatinine and decreased create clearance, then we should first try to optimize that creatinine. So that is beyond doubt. But the next question, or what Dr. Siddharth told, or what Dr. Ravi told, that say create clearance more than 60 is something which is stringent, especially if suppose our patients are 40-45 kg, elderly, bladder cancer would be something in 60s. So 45 kg, 60-year-old male or female, create clearance greater than 60 is not very easy. But their performance status good, no comorbidities, and if create clearance is 55, then we would try to push cisplatin even in this patient. That is what I wanted to convey.
Yep, sir, I want to say that not only an NYHA class 3, but I think in patient with somehow amount of heart failure or decrease here, because most of our patients are elderly, diabetic, hypertensive. In them also I think we should be
So,
thinking.
Yashwant, you pointed out it well. For cisplatin ineligible, the definition is class 2, more than class 2. For platinum ineligible, it is more than class 3. So, next slide, please. So, this is the definition for cisplatin ineligible. Next slide. Here, this is the definition for platinum ineligible. So, this definition is pretty confirmatory. So, someone with create clearance less than 30, no one would give cisplatin. Someone with more than class 3 NYHA heart failure, no one would give cisplatin. So this definition is something which I follow more religiously than what it was for cisplatin ineligible. That is what I wanted to convey. So if any other panelist has difference of opinion, so this is something, if we have create clearance of say 40 to 44, we would try to push carboplatin in these patients. If we have create clearance of say 55, 58, 56, we would try to push cisplatin in that patients. It is not a strict no, at least for me.
Do you divide the dose in day 1 up to day 8, or you give
Yeah,
single?
so that is again what I do in my practice. I do divide carboplatin day 1, day 8, sometimes in patients who are frail. So rather than not giving platinum, I try, if there is some way I can significant. So if suppose create clearance is say 34, 35, I would probably do carboplatin day 1, day 8, AUC2 rather than AUC5 day 1. So that is what how I practice, and I'm open to take suggestions from any of the panelists. Is that the same in your center, or do you strictly follow the regimens which are given?
Yeah, I agree with that.
Sure. Next slide, please. So important point to note is that these are the studies done in 2019. So it is reasonably recent study. Only around one third of the patients are able to take second line treatment. And for third line, it is really low. So these are aggressive disease. This is aggressive disease, and first line is something where we need to chip in and give as much as possible. Second line, majority of them won't be able to receive second line. Next slide, please. So say a patient who is cisplatin eligible, or say a borderline cisplatin eligible, GFR between 50 to 60. Do you have preference of platinum? Yes or no? And if yes, why? I'll start with Dr. Ravi.
So, to be honest, in the metastatic setting, I'm really not worried about cisplatin and carboplatin, and I would like to use more carboplatin than cisplatin. So
Okay.
my preference is more towards carboplatin in the metastatic setting. Whenever any dicey situation, I think I try to avoid cisplatin and put them on carboplatin. I feel more safe doing that way.
Okay, Dr. Rajiv, what is your opinion?
It depends what we generally like. We see if patient is eligible for cisplatin, we go for cisplatin, and if he is ineligible, so we go for carboplatin. Like we only choose by the criteria and not by like we generally we can go for cisplatin as well.
Okay, okay. Dr. Siddharth and then Dr. Yashwant.
Yeah, I agree with Ravi that if there is any dicey situation, I would go with carboplatin. Won't risk in a metastatic patient. But my preference would be for going ahead with cisplatin if that is possible.
Dr. Yashwant, any other view?
I just wanted to ask, you were able to give the full dose of carbo for 6 cycle, 4 to 6 cycle, or you have to dose reduce in gem carbo, because we are giving gem carbo.
So gem carbo, the main issue is generally cytopenia, especially thrombocytopenia. So once you have crossed certain number of cycles, there are chances that you would miss day 8 because of cytopenia. But if platelets are really low, that is how you need to give. We don't have great choices then. what the general take of panelist is that for cisplatin eligible, say young patient with GFR of 80s, 90s, generally no one will hesitate to give cisplatin. But most of us agreed that if it is borderline, we won't back on giving carboplatin. So we are more comfortable with carboplatin. So in literature, we don't have head-to-head comparison of cisplatin and carboplatin in this setting, but there is a meta-analysis which showed that cisplatin has some superiority over carboplatin, and hence the definition of cisplatin eligible and platinum eligible is different. So given a choice, as per guidelines, cisplatin is something which would be preferred, but practically I would agree that in dicey situations, in clear-cut cisplatin eligible, all of us would give cisplatin, but in dicey situation, most of us tend to come down to carboplatin and give. I think that is the general consensus which we are having. Next slide, please. So in cisplatin eligible, what is your regimen of choice? I would like to start with Dr. Yashwant.
I give Gemcis for eligibility.
Okay. Dr. Siddharth, your take on MVAC and dose-based MVAC for this category of patients?
So any patient with young and fit, I would consider DDA MVAC, but in general, my preference is Gemcis because I would avoid unnecessary toxicity in this setting.
Okay. Dr. Ravi, dose-based MVAC or Pecli plus Gemcis?
Actually, I have not used MVAC dose dense or neither seen anybody using that. Even in my residency, I have not seen any of my seniors using that. So I think everybody is scared with that regimen. And most of the times it is Gem Carbo and sometimes it is Gem Cis. And triplet has not shown to be of any benefit.
Yeah. So anyone have used dose-based MVAC and or Pecli Gemcis?
No.
Any experience in either of the regimen from the panelist? Dr. Rajiv?
We used MVAC once, I think 8 or 9 years back, but patient died after that. So really scared about it.
So I would agree with Dr. Ravi that because we have not seen people using it and we have not used it, we are a bit skeptical of using MVAC, and most of us would go with platinum doublet with gemcitabine. For triplet Pecli Gemcis, there is no overall survival benefit. There is some increase in response rate, but the toxicity profile is also worse. So most of us would go for doublet, gemcitabine doublet with platinum. Next slide, please. A quick take for cisplatin ineligible patient. This patient may be platinum eligible. So for cisplatin ineligible patient, platinum eligible, what would be your choice? Start off with Dr. Ravi.
I would go with IO if finances is not a problem.
Okay. So you would prefer IO over gemcitabine carboplatin in
Yes.
say someone is having GFR of 45.
Yes.
Okay. Okay. Dr. Yashwant.
I will if finance is not issue, otherwise Gem Carbo.
Okay. Dr. Rajiv.
Gem Carbo or simple Gem.
Okay. Dr. Siddharth.
Gem Carbo, if carboplatin eligible, Gem Carbo definitely, followed by avelumab maintenance.
Okay. Okay. So I would favor what Dr. Siddharth is saying, that we'll try to give carboplatin to such patients with, because the response rate is high, and as such we would give switch maintenance IO to patients who are affordable. So it makes more sense to me. But all the options listed are something which can be given as per the guidelines. Next slide, please. So Dr. Siddharth, what is the best place to use IO in the given settings? So you want to give chemo plus IO followed by the same IO maintenance, or post first line switch maintenance, or you want to use IO in cisplatin ineligible patient or platinum eligible, or in second line setting post chemotherapy progression?
So best place is post first line as maintenance, but platinum eligible is also a correct setting for it.
Okay. Dr. Yashwant, your take on chemo plus IO upfront followed by IO maintenance of the same drug.
As it has not shown benefit, and as sir said that post first line maintenance or in platinum ineligible.
Okay. Dr. Rajiv, any difference of opinion? Where would you use IO about in all the given settings? Where you would prefer to use IO?
Post first line as maintenance or platinum ineligible or even chemo ineligible patients where giving chemo might be very difficult.
Okay. Dr. Ravi, any other opinion?
I think I agree with all the panelists.
Okay. So, Dr. Ravi, any preference of IO? Say, if you are using in platinum ineligible patients, any preference of the
So,
drug?
yeah. So, Dr. Rushabh, to be very honest, I have two patients who are cisplatin ineligible, and I've put them on pembrolizumab, and both of them are doing well, and that is why I like to use the drug in that setting. And I don't have any experience with this newer drug, avelumab, so I'd like to use it. So I think I like to use pembrolizumab. I think it has worked for me, and I think it's a good drug to have. And I think only one this study we have, and we're talking about this switch maintenance, but I don't know, only I think once we start using it more often, we will get more idea as to how it really works for the patient, because you have to do chemotherapy also, then you have to put them on immunotherapy, whereas here you have an option to put them directly on immunotherapy. So I think I like it that way, to use single agent immunotherapy.
Yeah. So what you are using is not wrong. The only means when I am planning, the only worry is that the response rate with IO alone is not as high as what it is with chemo, and we will miss a significant chunk of patient in first 2-3 months because of progression. They may have poor PS and not fit for further treatment. But I would agree that if someone has responded to IO in first line, he will get the maximum absolute benefit of the drug. Uh, Dr. Siddharth, any preference of IO molecule?
So I have already told the most robust data is for post first line as maintenance of avelumab. For pembrolizumab, if a patient is platinum ineligible and there is high CPS score, then only I will consider it as upfront in cisplatin ineligible. Otherwise, chemotherapy followed by avelumab. That would be my preference in bladder.
Yeah, so what Dr. Siddharth told is again an important point for patients who are platinum ineligible. And suppose we have a CPS score of really high, say more than 50, more than 20, then that would maybe push us to use IO upfront. Vis-a-vis, suppose someone is platinum eligible, cisplatin ineligible, and CPS score is negative or CPS is really low. We may use gem carbo followed by avelumab maintenance. So that is a very important point which he made. And again, post first line as maintenance, we have data for avelumab alone. I don't think this is a place where you will switch Nivo or Pembro or Ates or avelumab or durvalumab. We may do that in some other malignancies, but the results of IO drugs and with combinations and with different trial designs is very different in bladder. So first line IO plus chemo has failed in with two molecules. I don't know why first line IO plus chemo is failing and first line IO maintenance is working, but that is the data what we have. So I would be skeptical in changing the IO molecule, at least in this setting. Say if it is RCC or if it is lung cancer, I may be comfortable in switching the molecules, but here I would be a bit skeptical. Is that what everyone would agree to, or do you have opinion? So if suppose patient has financial means is borderline finances and able to afford nivolumab, so would you use nivolumab in say upfront setting or post first line maintenance? Any of you? No. So I would also hesitate to use or switch IO molecules. So post first line maintenance, if I'm using avelumab would be the drug. I would be giving. Next slide, please. So this was the slide shown by Dr. Yashwant, that these are the options which we have. We already discussed today why we are not giving IO plus chemo upfront, and we would go for switch maintenance strategy. Next slide, please. So this is the data based on which we are deciding that for patients who are IO plus chemo was given, both the drug ATES and Pembro have failed to show overall survival benefit in cisplatin eligible or ineligible patient, and even durvalumab has failed to show overall survival benefit in this setting. Only positive data for overall survival we have is with switch IO maintenance. So as of now, that is the indication where we would use IO. Next slide, please. So what would be your choice? How would you decide on second line treatment post gem platinum IO maintenance? What would be the second line treatment of choice? Any specific investigations you would like to do? Next slide, please.
Rishabh, isn't this strange that we are using avelumab in a first line in maintenance setting, and there is overall response rate is very good, but whenever we are using in second line or first line upfront without maintenance, then data is something iffy, like not so.
That is the reason I told that for some reason we are not able to explain why IO plus chemo is failing with 2 trials showing no benefit on overall survival. Maybe it is because of difference in trial design. In avelumab maintenance, we are selecting the patients who are responding to chemo. We are not selecting the ones who are progressing on chemo. That may be the reason, or something else which we have not figured it out yet. So that is the reason we won't change the drug. Suppose you have a good PEP and you are able to afford some chemo, some other immunotherapy, I would not switch to other IO. Say patient will take nivolumab after gem cisplatin. That I won't do just because we don't have great data with all IO in this setting. But if you say why it had happened, I am not sure. One is difference in study design. That is what I could figure out. If any of the panelists have other opinion why it has failed as IO plus chemo and succeeded post chemo as IO maintenance.
No, that is the selection bias, I can
Yeah,
say.
probably.
That may be
So,
the reason.
avelumab,
Not sure about that also.
Did a great means they did a smarter design than what ATES and Pembro did. That may be the reason, but not sure.
And
So
in Dr. Rishabh, and in kidney, they failed big time. Avelumab plus TKI failed big time, and Pembro plus lenvatinib is doing wonderful. So just look at that.
Yeah.
I mean,
yeah. So means there are settings where you would be comfortable in switching IOs, especially Pembro, Nivo, something like that. But there are some settings where you won't be comfortable. This is something where you won't be comfortable in switching IOs just based on finances. Anyone has experience with FGFR testing or FGFR inhibitor? Usage of drug antibody conjugate. I too don't have any. So if someone has used or doing NGS for any reason, if you have found something which is targetable, any of the panelists, Yashwant, Siddharth.
Most of my patient was not able to take second line.
So that is obvious for all of us because only 30-35% of the patients would be able to take. But for me, most of the time it is Texans, and for some affording patients, IO. Else, everyone would get Texans. That is what is usually in my practice, and most of the time it is weekly paclitaxel, which helps. So, if there is any other experience or
but the most robust data is for enfortumab vedotin, and if it is available, it should be given.
Yeah, so we have good data for FGFR inhibitor. We have good data for drug antibody conjugate. So if patient is FGFR positive, and if that drug is available, that is something which we should consider for drug antibody conjugate. Now, as Dr. Siddharth told, there is upcoming trials with drug antibody conjugate plus IO, FGFR inhibitor plus IO. So this would be a dynamic field. But as of now in India, we don't have access to either of the drug. I've never tested FGFR, so I don't know how many of them would be positive and whether compassionate access drug is available or not. So if anyone has to chip in, if anyone has the experience. And
the studies say that 20 to 30% are FGFR positive.
Yeah, literature shows that, but I'm not sure like whether that would be applicable to our population or not. But
this
20 to 30% is a reasonable chunk.
This drug antibody conjugate is irrespective.
It is irrespective of FGFR. So it is preferable, and those who have FGFR positive, even in those patients, enfortumab is preferable. But you can use the FGFR inhibitor.
Actually,
so for
recently I have
FGFR
one
positive, both can be used.
Who progressed on this pembrolizumab, and I forgot about that drug antibody conjugate, and I sent for NGS and meanwhile started on nab-paclitaxel. So I think that would have been a better choice in that scenario.
Yeah, but I'm not sure whether they are available and how to procure them. So that is something, if someone is positive, we should consider for FGFR, and drug antibody conjugate has better data than most of the other second line drugs. Next slide, please. I think this would be the last slide. So these are the options which are listed in NCCN, which Dr. Yashwant already discussed. Next slide, please. So thank you, Dr. Yashwant, Dr. Siddharth, Dr. Rajiv, and Dr. Ravi. It was really helpful because bladder cancer are absolutely not very common. And second line bladder cancer is something which we don't do as common because most of them won't be fit for any of the treatment. Thank you.
So thank you. If anybody has any other thing to discuss, kindly discuss. So I would like to conclude the session. I think everyone wants to go to the dinner. Thanks BMS and Merck for sponsoring this session. Thanks for active participation, Dr. Ravi, Dr. Tarachand, Dr. Rajiv Ratan, Dr. Satyadev, Dr. Yashwant Kashyap, Dr. Amit Agrawal, and all the my esteemed panelists. Thank you very much. Thank you.
Thank you, Siddharth. Good evening.
Thank you. Good evening.